Block is number 4, called Challenges and Solutions with regards to the rational use of antimicrobial drugs. And Roman Kolesnik is going to be the one to moderate it. Roman, please, over to you. Hello, dear colleagues. Good morning. I hope everyone had a chance to get some rest, given the situation that we had during the nighttime. And colleagues, let's now discuss the antimicrobial stewardship program in Ukraine. We do understand how important the topic is, and especially in the context of the military warfare, the military situation, and also given the most recent report from the WHO that demonstrated how even more relevant the topic has become at the global level. And probably in Ukraine, I have to say this problem could be considered even more serious. Therefore, the issue of antimicrobial stewardship is something that we need to really focus on a lot. And the next speaker on prospective audit and feedback, how it works, gonna be delivered by Mykola Hajtovich, professor, head of Department of Clinical Pharmacology and Clinical Pharmacy, the National Medical University named after Bogomolets, and he is the permanent member of the task force dedicated to antimicrobial stewardship. Mykola, over to you. Thank you very much indeed. Colleagues, first of all, let me kindly thank you for the invitation to participate. Yesterday, unfortunately, I did not have a chance to participate, and probably I missed a lot, I guess. But let me try to share with you some novelties, if I may. So, in my presentation, I ask, how does it work when I talk about prospective audit? So I will try to share some experiences of mine. So we start with a case, of course. A surgeon applied to the epilepsy department with a request to identify the antibiotic therapy for the wounded patient to understand what is better. Man, 32 years of age, 2 weeks ago, gunshot wound, lower limb, fragmented injury, surgical debridement performed, drainage installed, ciprofloxacin intravenously as empiric treatment. As of now, 14th day of treatment, fever up to 38.8, tenderness and hyperemia. You see some basic test results, and we find Acinetobacter baumannii, which is totally resistant, and it is only more or less sensitive to colistin. So the diagnosis is clear enough: gunshot wound, post-operational purulent necrotic infection caused by Acinetobacter baumannii. I have to stop just a bit to remind you bits of theory, I guess. So why I like this slide very much? This is the one that demonstrates how many people die from resistant bacteria, from resistant infections from all over the globe. It looks like that prognostically the European region looks pretty safe. But if you now go deeper into this slide, the situation looks different. You see that the north of Europe is bluish, and that means there is a lower level of mortality associated with antimicrobial resistance. That was 1990. 2021. The Northern Europe remains to be blue, but we have different color in our region, which is associated with the increase in the mortality rates. And that also says we're, sincere enough while registration of these cases. And this is the prognosis for 2050 for the European region, well, our region. So we need to think of that, and according to the prognosis, to the forecast, the situation might be pretty complicated. We have some baseline documents, we have some guideline documents, and I really hope everyone has it in English version available. You can also find some bits of that in Ukrainian, focusing on intervention interventions, AMS interventions, and these are the ones which are very much focused on countries like our type, like mid and low-level income countries. And the key principle are as follows. We need to use the modern approaches to prescribing, and we should not be afraid, should not be ashamed to do what is suggested to us with regards to modern changes to interventions. So, what we do first? We prescribe the antimicrobial primary therapy based on clinical situation, given the laboratory test results. But the problem is not about that. The very common situation at this stage, you have very many points like pre-authorization and discussions, but the problem is about something different. The doctor prescribes it and he forgets about that. Nobody reminds about that. So in 48 hours, there is no revision. This is the problem. So this low level of changes of this empirical primary assigned therapy is the biggest problem. That is the backbone. So let me remind you, there is a mandatory requirement. 48 hours after, you need to review the prescribed therapy, and that gives you a lot of positive things. You will not be able to compensate any other way. We will speak about prospective audit with a feedback. This is how they call it in the literature. Sometimes they call it the prospective pharmaceutical counseling in our country, and probably you understand why, because they decided to put the responsibility on the pharmacist. But when you put some hopes on somebody, you can either break the person or maybe the expectations might be compromised. So you always need to take into account the risks and you have to assess risks. So whenever we talk about this kind of audit, it is not about pharmacist. It is about the whole team-based approach. In our country, we call it prospective pharmacist consultation, which is very much focused on pharmaceutical counseling. And that is not actually a mistake. That is an attempt probably to make the pharmacist be a powerful, capable member of the team. Maybe that's another step to kind of, make everything possible so that this team member could be considered as a team expert in that field. So revision must be done by the physician, but on our standard, there are some requirements where you need to perform it together with the pharmacist within this prospective pharmaceutical counseling. Well, we have some requirements to that, as you can see, saying that the pharmacist is supposed to be involved, the physician is supposed to provide clinical and laboratory information, which is reasonable, and then the decision should be made. When? The standard outlines certain indications for that. And let me stress upon some key points. Number one, lack of results of microbiological testing after 72 hours. Well, in the hospital, you're supposed to get the result, right? Well, but you don't have it. So this is a good indication to engage the pharmacist. Ineffective antibiotic therapy of the first line. Well, this is a requirement for pharmaceutical counseling. Well, number three, duration of antibiotic therapy over the period which is approved by the protocol. Let's say community-acquired pneumonia, 5 or 7 days, and then you have to revise, you have to review why do you treat it for 7 days like that. So we're now we're now developing the summary for our thesis in kids with community-acquired pneumonia, and the average treatment is around 7 days. Of course, there are changes, there are things that keep changing all the time, but still there are some markers that you need to use. So, duration of antibiotic therapy over the period approved by the protocol. The next one is prescribing the reserve group antibiotics, colistin, for example, some severe infectious diseases like sepsis, and escape infections. This is also when you want to engage such kind of counseling. Special patients, it was not indicated here also, but they wanted to mention the drug-to-drug interaction. So these are the aspects that the pharmacist is very well aware of, but what often happens is that such kind of counseling may not be very constructive. It does not always depend on the pharmacist, I have to say, but I'm just drawing to the fact that everyone should be aware how to do that. Okay, let's get back to facts. Just last year, we conducted a survey. 50 pharmacists have been involved. They work as the clinical pharmacists, and 100 physicians have been involved. Epidemiology, microbiology, infectious diseases, doctors, surgeons. So everyone who attended our course of AMS, and this is the ones who are dealing with the antimicrobial resistance issues. So everyone thinks that training can help. Well, but training can only help you when you don't only want to learn, but also you're ready to implement it. So you heard it today, and tomorrow you implement it in your working activities. And then in a week time, you don't forget about that. You get your experience, positive and negative, and you can provide your feedback, saying like, well, sorry guys, your technique is not operational, but the process has been started. If we're talking about training or education as a passive intervention, well, it can only be more or less effective during the training activities. When the hospital has got some experiences already, you conduct a training to change some bias or maybe some prejudice in people. But we're talking about prospective audit with a feedback. So only 9% of people think it is effective. Over the globe, people think that is the best approach. And from the point of view of evidence-based medicine, they say, well, that's the best way to use it. Let me try to explain why it is not so operational and what kind of problems do our colleagues come across. I would like to split it into 3 blocks. Block number 1, I would call it administrative drawbacks. This is when a hospital either does not have a chance or does not have specialists or does not have antibiotics. So something which is more like a hospital problem than the physician's problem. Number 2, lack of resources, lack of funding resources, lack of laboratory resources, lack of some antibiotics. You exhausted the stock back in summer and you still don't have it. So this is about a lack of what you need, and you come across it like everywhere. Even in the US, 40% of medical staff think that they lack laboratory resources and laboratory funding. And the third block is problems with team building, problems with development of SOPs, lack of leadership, which is very important for many hospitals. You kind of have the team, you have the clinical experts, you have the pharmacist, you have people in the positions, but there is a kind of a social, psychological barrier in place. We conducted another survey. Just recently, it was September 2025, and I would like to thank you, colleagues, those who participated. These were only clinical pharmacists. One person indicated that he was not employed, so we decided to assess 49 out of the total. Majority of them, 44, have been working in this position for more than 1 year. That is a serious experience, I would say, and I would say these are the people who are now in the very flow, inside the flow of these changes. So we asked them, how often do you perform this prospective audit? And only 1/3 said seldom. So every 5th person basically does it every day. Half do it regularly, and only 1/3 do it seldomly. But there was also a statement saying that inpatient physicians do not consider that important. On the other hand, well, I told you half of people do it on a daily basis. That means people are quite overloaded, quite overburdened. And if we look into the literature, we see that this prospective audit with the feedback is actually the best tool, the best approach, actually, to get good results. So you want the expert to be very well trained, to be properly aware of everything. So on the one hand, it's good, they are busy and they do it regularly. On the other hand, you should stay away from overloading the given specialist. The next question was, what indications did you have prevailing for prospective audit? Well, these are quite compliant with our standard. The reserve group and request from the doctor, I would consider to be the most important and prevailing ones, 76 and 74% respectively. So you see, it is not by chance that we have this half of our specialists doing the job regularly on a daily basis. So what recommendations were perceived the best way by the physicians? That's a pretty complicated question. You see that the results are pretty high, and they are, somewhere around 40%. So you cannot single out one leading recommendation, so to say, that could be perceived like that. Am I okay with time? Just to make sure I'm okay with the timeline. Sorry. So what I would like to focus your attention on is that, please, colleagues, pay attention. About 1/3 already of the total have some experience on what works best. Of course, what works best with the physicians when you let them continue the antibiotic therapy. Escalation, well, they like it. Of course, it works better for them when you give such a recommendation to them. But you also want to have the de-escalation related recommendations in a proper way whenever it is necessary. Some separate statements were as follows. Well, the physicians do not perceive these recommendations at all, and they just act on their discretion, though there are some SOPs available. The physicians do not follow the recommendations at all. Another statement. So what are the reasons for this incompliance with recommendations? And I have to say, it is not always the physician to be blamed for that. Because, well, there are some SOPs that make the physician to behave like that. There are some complicated clinical situations when the physician listens to you, but has to make a decision. And you need to, feel yourself in the shoes of the physician who's responsible for the health of the given patient. It is the physician and only the physician. So whatever and no matter how much you talk about this perspective audit, feedback and stuff like that, the responsibility eventually rests with the doctor, with the physician. So when we talk about this perspective audit and pre-authorization, and if we try to compare it, well, they have very different functions. The perspective audit is about counseling the doctor to make the doctor make the optimal decision. Both, it will be beneficial for both with regards to their education, with regards to their learning, because in a couple of days they will see the results of their decisions. When we talk about pre-authorization, well, you don't have it like that. It is only about banning something, right? And for the doctor, it's like a complete ban. If you cannot justify why you want to use this reserve group drug, well, you're not allowed. Speaking of counseling, well, you can refuse from this recommendation because you are the one responsible for the health of the patient. So after the consultation, the physician makes a decision. And you can discuss this kind of discussions. You can discuss it later. What were the results for your patient? You can discuss it during trainings, during educational activities and stuff like that. And the question is, do you discuss these cases of prospective counseling during trainings? And that is a problem, by the way. Some people say yes, some say no, but 1/3 say no. And that is a big problem as of today. Probably this is one of the biggest problems I wanted to raise for you, dear colleagues. And the question about do you want to improve your knowledge and skills? And let me get back now to this pre-authorization. So it says for prospective audit, the specialist needs to be trained in two aspects: the proper knowledge of clinical infectology and the good communication skills, because you need to be able to communicate that. So the communication skills, our colleagues do not consider to be important. They think that knowledge of infectious diseases, the knowledge of molecular, well, antibiotics and pharmacokinetics, of course. So getting back to my case, We have planned a training course dedicated to AMS and AMR. It is supposed to take place somewhere, if I'm not mistaken, somewhere in the fall next year. And we want to make it really focused for the pharmacists. So they're going to be really looking carefully into this pharmacoresistance, AMR resistance. So let me remind you quickly how the case looked like. So probably there is a need for some counseling from the clinical pharmacist. Is it unique? No, no. This is the data from Vinica, Acinetobacter baumannii, very common, very resistant. Some good information from our colleagues. Acinetobacter baumannii is an actively developing pathogen, especially in immunocompromised patients. And the fact that it is resistant to multiple drugs is not a secret to anyone. And colistin basically is the only molecule that is that the microorganism is still sensitive to. So what they do, they use colistin and tigecycline. That was the decision. 7 days treatment was effective. I did not follow that situation any further, but what I know, it worked. Where did we get this combination of colistin plus tigecycline? Well, there are some evidence-based approaches, and this search for active combinations is always, working. And Olena proved, for example, I see my colleague, that azithromycin brings back the sensitivity to meropenem. We were told bactericidal, bacteriostatic antibiotics cannot be combined. This is nonsense, but now we got a different situation. So our cognitive bias, were refuted, and based on the evidence-based approach, that worked. So a similar situation here. So there are some combinations that work better. And for some reason, colistin and tigecycline perform pretty well. And to conclude, let me give you an example from Japan. A nice hospital, 972 beds. On their team, they have 2 specialists dealing with that issue, a physician, infectious diseases physician, and a pharmacist. So what they do regularly, every week, they assess patients with bacteremia and patients that receive antibiotics for more than 7 days. So 2 main aspects of their prospective audit. More than 7 days, for some reason, why? They investigate that. And bacteremia is the second option, the second indicator. What they gave them? Well, they reduced the 30-day mortality rate, the health-associated infections-associated mortality. And the conclusions are, well, we already have clinical pharmacists, we have clinical physicians available, we have specialists available to do that kind of job. They're supposed, according to the regulatory framework, to perform this kind of work. Just as usual, just as always, actually, when there is something new being implemented, they, of course, come across a certain systemic resistance. That's fine. But that's fine, because everything new that you want to implement, it bumps into this resistance. But it will be implemented, and that will provide you with some good results. I hope that our Congress is yet another good signal to the fact that it operates well and that functions well, unless you never knew about it before. This is something I would like you to remind about. Oh, thank you very much. Let me remind you, colleagues, we're going to have a chance to ask questions after the session is over. So, dear speakers, do not forget to take your seats when you are done. And I suggest now we continue according to the agenda. And getting back to agenda, I would like to give the floor to the next speaker, who will speak about the implementation of the AMS programs in a healthcare facility. Often the case, the IPC department people ask to share their clinical cases, to tell us what to do first, tell us what to do next, what works well, what doesn't work well. So in order now to share their experiences of implementing the AMS program in a large-sized hospital, I would like to give the floor to the clinical pharmacist, of Zhytomyr Oblast Pediatric Clinical Hospital, Yulia Lukyanchuk. Hello, everyone. Hello, colleagues. So today we're going to speak about the implementation of AMS system, AMS program in our hospital. I am a clinical pharmacist, so we will speak about that from the point of view of a clinical pharmacist, of course. So the common challenges, well, it's not a novelty for you, of course. So we know about that and we came across that. But what I would like to focus on, war and multi-drug resistance. When the war came, unfortunately, we have to admit the flora that we face has become more aggressive, and it is almost totally resistant to all antibiotics available in Ukraine as of now, unfortunately. Another problem, self-care, availability and easy access to antibiotics. That is associated with the problem that for a long time there was no electronic prescription available for antibiotics. And even now, when it has been implemented, there are still pharmacies where you can still buy an antibiotic without a prescription. Whenever I go beyond Ukraine or I travel and I talk to my colleagues, the last colleague was an infectious diseases doctor from India. And I have to say, we have quite a number of similar problems, just like they have in India and the Indian healthcare system. They can also buy any drug, any antibiotic without prescription in India, morphine, some other drugs, which is like, next to impossible, totally impossible to buy in developed countries. But that is totally fine to do that in Ukraine and in India. Prescription of several drugs which should not be combined.
In our health facility, IPC has been created in 2022, so this was the early institution, essentially. So this was in the January of 2022. Unfortunately, when the war has started, it was all rolled back at the time. And so we started to work in around the August or September of 2022. On that period of time in our team, we had a clinical pharmacist, so me and a coordinator on the hand hygiene. And for the quality implementation of the program and for and infectious control, this is not enough. So 2 experts, and I remember our first meeting was the administration, the first meeting was the director. So then we were told that everybody's working in their area of work. So I working in the administration, antibiotics, and that period of time, there was not a lot of information where to take it from because this was like a brand new thing, but we were taking the information from the speakers that are presenting right now. And so their lectures, so they were motivating us. And I had an interesting experience because Mikola had helped me in this in terms of in March of in May of 2022, the Congress has been conducted on Yulia Zabrodska, an infectious disease doctor who was in IPC at that time. And so they did a joint project with Mikola. And I watched the Congress or the conference, to be honest, I don't remember word for word, but the last phrase, if somebody wants to have any help, somebody wants any assistance or to implement it in the same way, please get in contact with me. So I decided to get in contact. She did not leave her phone number. So I called to the registration and then she called me back. And then we get in contact. So I came to her hospital. So this was Kyiv City Hospital. I looked at how she worked and what she had. So she had shown me like what did they have and how did they work. And for that period of time that was completely new to me. She got me in contact with another wonderful expert, which is Helena Filodenko, who is a bacteriologist. And so we had this multidisciplinary team. So they were both in Kyiv, I was in Zhytomyr, but we have periodically had a call. And then Yulia had an interesting interest into the IPC. I guess the first doctor to whom I had seen such an interest, such a high enthusiasm. She did a lot of work. And then we had work in this area of work. So for interdisciplinary team. We were lacking only the epidemiologist. Unfortunately, at that time we didn't have. So what did we start to do? When the Helena Fimonenko started to open up the EU class for me, I looked at the fact that there are many things in the bacteriology lab. So when I started to talk to Yulia and I saw which moments are still in the administration that we still need to make better. And so if in your health facility and if in your region you don't have experts and I see that they're lacking, so maybe to create such a team, it's worse when the expert who is needed, who is not in the city, who is just somewhere in a different location or in different region. This is possible because we have created Zoom links. We have added my doctors that have been interested in this, which was head of the ICU department and also an epidemiologist from one of Kyiv started to work with us. And so we have created a team. And then later on, as you can see, in 2023, that this was later, we were able to find our epidemiologist. And also the medical statistician has joined us. The area of work, I'm not gonna surprise you, this is the prevention of the infection in the IPC. This is the administration of antimicrobials. So my hospital, which is the 300 beds, which is not as big hospital as yesterday for 700 beds or something, but this still is a good chunk of work if you would go in detail. And so you can see the departments. We have the ICU department, which is 12 beds, which is newborn and the children of more adult age, essentially. We have palliative care patient, which is observation, and a lot of work that we can do. This is the structure and organogram that we have right now. This is not a prepared picture. This is a picture that was made when I was conducting a presentation because frequently in my hospital, I'm making presentations. The topic was the preparation to the accreditation, prevention of infection, and IPC. So there was 70 questions, so I had to quickly tell how things are done, how if IPC is being done, and how the administration of antimicrobials is being done. So in my facility, periodically, there is training for doctors, medical nurses, and non-medical personnel in terms of use antibiotics. For non-medical personnel, this was for the accounting, and for the economists, we are making lectures, which was the culture of consumption. So here we need to simplify things from what I'm telling to doctors. So they being told to them that you need to take antibiotics only by prescription of a doctor. But if, for example, it shows that you're taking them without a doctor's interventions, how to at least minimally to do that correctly. And so we also have the testing in the facility. This was conducted not all the time, the testing for doctors. This can be a Google form test for testing or on the paper-based forms. So from this year's, I had started, not me, but in the Kahoot system, we have testing. This is me conducting in a different hospital because right now I started to work in a different hospital as well. In the Kahoot system, doctors are interesting. Who haven't tried, please try the Kahoot system. For me, this idea was given by Natalia Alieva from the previous Congress. I think you heard today in the pre-authorization of the reserve, and I'm not going to surprise you here, the implementation of methodology of EUCAS. The most interesting matter for me and the one who had the most energy to spend. In that, I was really helped by Helena Fimonenko, because even this year for my bacteriologist, she did conduct a webinar in Zoom. So we've learned how to correctly interpret, how to fill in the gaps, and so how to work correctly, because without the bacteriology lab, the IPC department cannot really work, and this result has to be correct and of quality. And so I am always highlighting this. So what was done from my side is the SOPs developed on EUCAST and also implemented the WHONET program and updated on the blank of the results. I can't say that this is perfect, and you can see on the left And then we had this before, and this was always worse. It didn't have the any distension zones. And so here the doctor can see what was done, was the MIC or was the disc, because colistin is only done by the direct one, and vancomycin for staphylococcus is only done by the this MIC. And therefore, it's important to state the clinical diagnosis, because depending on the clinical diagnosis, the bacteriologist can differently put the sensitivity and susceptibility, and this is why the changes happen. So it's important that in the health facility to have the selection of medication. If, for example, the doctor has the choice of two medication, out of which he can, for example, ceftriaxone and cefazolin, and we are requiring from him for him to treat, for example, with the suspension or the with the so this is double standards. And so it's important for clinical pharmacists to participate in procurement, so he would to correct, because if he's not participating, then it's really hard to change and to influence any of those matters, because the first thing that I've started off of, and then what I recommend to start, which is the variety. When you have the variety of medication, when you can see which percentage of what you have, then from that on, you can later on try to base your opinions and decisions on. So I'm also revising what is being procured by our bacteriology lab. So first I was helped by bacteriologist Helena Fimonenko, but now I'm doing this myself. And so you can see that we have increased in the numbers. Before Cefixium, we did not have. And when I mentioned to doctor that it will appear, they didn't even believe that we will have it. Not likely, no. And so this is the critically important to influence procurement. Here, I don't think it's going to be surprising to you, because the result is like in others. The decrease in use of ceftriaxone, increase in cefazolin, meropenem is almost at the same level, but unfortunately, there are some increases that are happening for linezolid. In why linezolid came out higher, because linezolid at the time when it as vancomycin, when we really needed, we did not have it in the facility, so doctors had to prescribe linezolid. This is why we had such a situation with the growth in linezolid and colistin. So it was almost the same. So what I had changed to the procurement has been conducted to be conducted once a year of antibiotics. Right now, we are procuring it frequently, because it's impossible to calculate per year, per half of the year, what would be the need for the whole process. For doctors to understand that we are not prohibiting, but controlling the prescription of ceftriaxone, we can't come and then say that ceftriaxone had to be put somewhere to use. And so this is important for them to see changes. And so you can see, let me repeat myself, the present assortment. So that the access of an A is spread out a lot, and each year it's going out. For me, it's critically important, even though a supercluster facility, and usually patients are coming being treated, and most of the medication they've received in other facilities, but in some of the moments, we can still pick the medication of the access group, which is, for example, I can make an example on the ENT department. It's almost not taking this third generation medication, not cifotoxin, not ceftazidime, they're not using mostly. They can reach out to me once in 4 months, and so they're fully moved to amoxicillin, clavulanic acid, or cefazolin, and sometimes tifuroxime. So before, they acted in a different way. So in traumatology as well. So those departments, rarely there's any issues with them. And personal consultations on the antimicrobial treatment. I have a few minutes. So how in our health facility things are happening? So I've been invited into the consilium. And so if there are any complex cases, and if, for example, it was a complex patient or severe patient, in some cases, it can be that the doctor is just asking for help. And this is critically important when they're seeing that you're interested, you're included. So clinical pharmacists, the department is interested not to order to do something, the main message of the IPC department, but to support. And so in that part, you just always need to make a highlight that. So this is the concilium, and this can be the consultation on the phone when I'm absent on any other reasons. So this is a lot depends from the doctors. If the doctors are seeing and they understand why this is needed, this can be frequently happening. And if not, if, for example, it's clear that maybe in surgery that's less, pediatrics this can be more. So this is more so for personal communication and might be connected to. So this is something that you need to build. And you can see that outside of the bacteriological mirror, you have a cumulative antibioticogram to a period of time in the surgical department. There has been a bacterial mirror. And so I think that many of you have heard of it, maybe even doing it right now. So now the cumulative antibioticogram that are showing the percentage of the susceptibility, which is also critical, important for doctors when they are conducting empiric treatment and when you need to explain a lot. So what can this give them or make them, and what improvements did they have from this? It's also an interesting indicator, the frequency of de-escalation after the results of microbiology testing. So as you can see that unfortunately in my facility, I don't know how it happens in your facility, the percentage is really small. So it was 10% before and now it's 30%. So why does it happen that way? Because microbiology result is after the patient is discharged, for example, they were taking for a weekend, and it might happen that they might not even look at that microbiology result. And so they see that clinically the patient is feeling better, and then it's not important anymore. But microbiological testing of the results, it's really important for the understanding of what kind of cultures and what kind of susceptibility in the health facility. This is why you have to highlight on that. And what I'm doing is that just saying that you did a good job, you did a good job. And when you're making a selection, because I think as everybody else, you have the group meetings that you can bring this up on, because the departments one in front of another, they want to be in some parts better than others. And so you can see the cumulative antibioticogram. If you are to take a look at that SROs, we don't have a big issues, and Klebsiella and Pseudomonas aeruginosa, we have an issue. The only medication that right now, 98% susceptible to Klebsiella is colistin, unfortunately. And we will be looking on top of that to think of what can we do, because colistin is not an immunotherapy. It can be prescribed only with something else. And then the conclusions that the interdisciplinary cooperation with the bacteriological lab has played a key role in the provision of the sustainability of changes. And it's important to have the communication. It's important to have for you to be a bridge of the clinical pharmacist, to be a bridge between the departments and the lab, because frequently this connection is being lost. And you can see that educational activities for doctors has become an important instrument to change their clinical practice. And so they are aiding in the awareness raising. This is sort of a feedback that has to be there. And so that they have to see that apart from the order, there's still something apart from that that is critically important. Thank you so much. Well, thank you so much. And I hope that this experience would be used by you in your health facilities, and you'll be able to improve your approaches to the implementation. And then we are continuing to have our event happening in practical cases that are present in Ukraine. And so for us, they are much more important that you can do them here and now, as previously mentioned by Mikola Khaitovich. And then to the floor was the presentation of the challenges and it's an implementation of antimicrobials. We are welcoming Dmitro Kurilov, the head of the IPC department and Unity Clinical Hospital.
Доброго дня, шановні колеги.
Greetings, dear colleagues. I'm not gonna tell you about the department, and last year I told you about all of that. We can start off with the more of the practical activity. This year, we have dedicated fully to matters of reduction in HAIs, the antibiotic stewardship, monitoring for resistance, audit of perioperative antibiotic prevention, and then I'll show you the numbers and what does it give to you. The increase in the level of safety for a patient, increase in the compliance of personnel to the hand hygiene, which is important in hospitals. And by thankful to our Vita Posuna who teach half Ukraine and how to wash their hands. An improvement of the control on the reprocessing department, sterilization and reprocessing, because this, as it turned out, and we still had to redo everything. In my statistics in the surgical site infection for 2024. So here is not in the numbers, but it's in the percentages. As you can see that 25%, the most surgical site infection, which is the burn department, where patients are with the military trauma, and where patients are with the burns. The second place took the planned surgery, no matter how you would look at it. And then urgent surgery, traumatology had less surgical site infection. In 2025, in 10 months of 2025, we can see a significant increase in the surgical site infections in the burn department. It almost grows in 2 times in the, even though the last 3 months we have the increase this trend. We went there, we worked in the department, we worked with them, we worked with doctors, with the head of the department, with all the personnel. So we told them, we even had official letters with them, inviting them, giving them recommendations. Nothing had helped. And so the numbers has continued to grow. And the usage of antibiotics has started to increase, especially of the reserve, because HAI with Klebsiella and other things. So we were having it, so we went to the point that we are putting the note to the director together with the administration. We are going into the department and we're telling that here it happens this, and this. So you mentioned this, we did this, nothing is helping. We just need to do something because the use of antibiotics is increased almost 2 times, and an increase in the HAIs. So we are closing the department and we are making the general cleaning. And then later on, let me tell you what will be done. And after that, each day, the IPC department is going there and tracking the whole process of IPC. So what does it give us? In 2 months, we are not having no surgical site infection with the gram-negative flora that's present in the hospital. So what did we do? We did the clean sector, or the sector for plastics and recovery in that department, then the sector for the military trauma, and sector for the thermal burns that are not connected with the military trauma. The patients has been placed on the nosology so that we wrote this down. So we talked to with the head of the department. Nobody heard us until the administration of the hospital has actually heard us. So here I want to show you how we separate the department. That is in red. This doesn't mean anything that they had the dirtiest patient. Let me just show you that we did 3 zones in the department that we separated one from another and separated on the diseases. Then here I just wanted to show you the zoo that we have in our hospitals, which is our surgical site infections that are practically are not treatable. In practice, they're being treated, but on the laboratory testing, it's just the situation is astounding. The reason for reorganization of the department, as I mentioned before, that the significant use of antibiotics, and so the pond resistance started to appear, and then increase in the surgical site infections. So each sector and that department, so what I showed you on the previous picture, they have their closed ones, and then there is the lock system, meaning that there's only a separate medical personnel is working there, so there's no interchanges. So each sector opened and their own sector, a surgical room and the rebandaging room. So every sector has the interventions room, and every sector had their own medical personnel. So in each and every sector, there is their own nurses and their own junior medical staff. And each sector has a medical post for contact. This is a bit of statistics. Yesterday, I've heard from the whole, how are you calculating? How are you getting all the numbers in and how to do everything? So it's all being done simply. We are just tracking the use of every ampule of medication. So we have a statistics on the 2024. And in 2025, we have already, for 10 months, as you can see, meropenem has decreased in 5%, imipenem for almost 50%, linezolid 60% decrease, colistin 24% decrease, polymyxin, we almost said no to it, levofloxacin 7%, ceftriaxone for 70%, cefazolin for 36, compared with 2024. Let me explain why did we have the increase in the usage of cefazolin. So how all of that has been built or being done, as you can see, the consultation with the IPC, clinical pharmacist, and me, we are constantly in control of every admission or every use of antibiotics, 48 to 72 hours, which is sometimes when the doctor knows that he has antibiotic for 3 days, and he needs to reach out to us to either to continue the treatment and it's effective, or the treatment is not effective, and then we're together, we're joining in and then prescribing the medication of the wider spectrum. The assessment of empiric treatment. So this is why cefazolin has decreased. So because the doctor started to treat cefazolin as antibiotic prevention. In accordance with the up-to-date data, cefazolin can be treated, but you need to increase the dose of the medication. That financially was not great in the end, because the price for cefazolin and cefatoxin is almost the same. And the de-escalation based on the results of the microbiology testing. In 3 to 5 days, we would have the results, and then we are looking at what is growing and what can we do later on. So we have an increase in cefatoxin for 120%. And let me explain why. And then cefazolin, cefatoxin has increased. So this is the that the doctors that they started to work on the protocols. And then for the cystitis, pneumonias, and for everything else, and also war pathology, and almost everywhere there's cefatoxin. Ceftazidime and vancomycin has increased in numbers. This is connected with the fact that we moved into the work of with 2 of the medication with aseptic states. So the patient is getting into the hospital and he has sepsis, then we are covering all the 4. We're going from gram-negative and gram-positive. We're using vancomycin, gives us gram-positive, ceftazidime, meropenem, and goes for gram-negative mostly. And because of that, we have the use of ceftazidime and vancomycin. And so the use of vancomycin has increased because we open a cardiosurgical department, and endocarditis, the protocol says 4 to 6 weeks of vancomycin. And we can't do anything with that. And the third thing, vancomycin has increased because doctors are starting to do the prevention with vancomycin where it's needed. This is really great. And I didn't want to show you the tables, but I just wrote down with a sentence that in general, over the 9 or 10 months and the savings for the medication compared with 2024 is almost 3 million hryvnias.
Ми зробили свою
So we
антибіотикограму.
did our antibioticogram, and so we've been at the Congress, and then last year we've listened to this, and for the year we've analyzed ourselves, and so we did our own antibioticogram. Yes, it's scary. This is really scary because as we can see, almost all of the gram-positive flora, it's all susceptible, all great, almost 80% susceptible, almost to every medication. So we are not afraid of gram-positive flora. It's great. But all the gram-negative flora, it's not even in some of the cases, it's not reaching 80%. Weston is the only one who can help us, even though we need to know how to use it because what is written in the literature is not clear.
Гігієна рук.
So hand hygiene. Hand hygiene, which is the basics of the infectious control, which is 80% of your success stories in infectious control. This year, we were able to reach to the hospital, finally procured and equipped, not everywhere, but in the departments that has been the most critical, we are provided with the hand hygiene station. So we did the hand care areas near the washer room in accordance with the order. You can see there's no antiseptic there. Everybody knows that antiseptic is not supposed to stand on the faucet. So we've taught the surgeons to clean their hands, to process their hands. Constant training. This is our chief nurses that are being constantly studying and bringing information to the masses. And because of them, we are sharing this virus of IPC in our hospital. This is what I want to show you, the hand hygiene. As you can see that this is one of the interventions room, small interventions room. So everything is great. We finally have the folders, dispensers. And so the greatest thing, which is the dispensers that we put down into our critical departments, which is the department and stroke centers where there's a lot of severe patients that we are taking care of for a long time. And so we are noting down most of the surgical site infections and the clinical case. What I wanted to mention to what does not fulfillment of infectious control can lead to. And then all of that has been highlighted in the very significant fund loss and even the status of the patient. The disease of the patients are leading to the complete consequences. If you can see, 21st of the November of the 19 October, not hospital DN1 or 2. Those are the people that are functional, can walk, and then would require some small oxygen support.
До цього він побував в 2 лікарнях.
Before that, the patient was admitted to 2 hospitals. Number 1, he was admitted with acute bronchitis. He got amoxil and levofloxacin. Interesting, right?
Стан пацієнта почав прогресувати.
The condition progressed. Some kind of a dyspnoea appeared. He was referred to the higher level of care with a bilateral polysegmentar pneumonia. Bilateral polysegmentar, severe condition, DN2 and 3 stage, acute renal failure of the first stage. Imagine what drug he got there? Amikacin. So we ended up with the following: encephalopathy, severe, hypoxia, severe, pneumonia, severe, admitted to our hospital. And the very first day when the patient was admitted, I came to assess. We started with what? Meropenem to cover gram positives because it was only amoxil, and I think it was pills. So we also give linezolid. Why linezolid? Because we see the renal failure progressing. I don't want to take the risk. I want to minimize his risks to his life. Maybe it was not the best idea at the moment, but I'm trying to save his kidneys. 24 hours after, the trend is negative. The patient gets intubated and referred to ECMO. and acute replacement renal therapy. Sorry, my time is up, but give me just 2 more minutes to finish the case. X-ray, sorry, this is the right side. Sorry, you need to rotate it. The other 2 are fine. So this is the case. This is the pneumonia in the patient that we have. We have been fighting actively for the given patient. Meropenem linezolid 24 hours after, when he got to ECMO, he got a daily dose according to the order on antibiotic therapy. And we are looking into the last resort option, Zavicefta. There was a suspicion. It was not a community-acquired pneumonia. Look into X-ray 24th, 27th, and the 30th of October, every 3 days. You see the dynamics, right? We can see the lung, start to see the lung. But the poly-organ failure starts to appear. The kidney, artificial kidney, is doing fine. The creatinine dynamics good. The patient stays on ECMO, comes back to consciousness. We even stop artificial breathing. And this is the final result, November 6th. No pneumonia. It looks good. Looks good. But no kidneys. And we are now in the situation of sepsis. What do we get? We got it from sputum and from washdowns. Acinetobacter baumannii, 10 multiplied by 9. 10 to 9 to the power of 9. Pseudomonas, 10 to 4. And you see the diagnosis changing. So it was hospital-acquired pneumonia, not community-acquired. The cost of treatment for the given patient. Oh, guys, I don't even want to voice it out because that was huge amount. ECMO was terribly costly. But we have been fighting for the patient, young guy, 36. We really wanted to save him out. This is how it looked like. One of cases of hospital-acquired pneumonia. We made it, but there are very many buts in this case. And to conclude with, colleagues, infections control is about the rational use of antibiotics. It is about perfect, flawless hand hygiene, isolation and barrier-based efforts, sterilization of tools, decontamination. And it is only due to combined efforts of IPC specialists you can get the good results. And without proper administration support, administrative support, you can hardly achieve good results. You need to prove your administration people that you are effective, that you can save money, you can help, and that also brings to the good status of your hospital. This year, well, it just happened to be so that the IPC department was the department of proud, and we really became the best department in the nomination, the team of the year. Well, thank you, colleagues. Over from my side, very best words to my colleagues from IPC department. I know, colleagues, you have been watching me. So that's it. Thank you, everyone. Thank you very much indeed. Don't run far away. Don't try to flee away from us. Okay, colleagues, and we continue. We had a chance to look into additional examples of IPC programs implementation, what can be changed and how to do that. And the last presentation on this blog is going to be dedicated to an example of an algorithm of implementing standards of care in a clinical center for pediatric medicine. I know, colleagues, many of you watching us, you ask questions on how to do that. and hopefully we will get some more examples on how this could be done. Oksana Horbolinska, over to you. Please, Oksana. Hello, everyone. Hello, colleagues. I represent the Clinical Center for Pediatric Medicine. This is the only multi-profile supracluster hospital of Lviv Oblast that has been formed as a result of merging two hospitals, specialized pediatric center and the Okhmadit Hospital, the Western Ukrainian Specialized Center and the Lviv Hospital Okhmadit. As of today, we are one of the most powerful centers for pediatric oncology. I mean, one of the regional centers, hematology, bone marrow transplantation, surgery, organ transplantation. And also we are recognized as a national reference center for treatment of multiple orphan diseases like cystic fibrosis, spinal muscle atrophy, SMA. And as of today, we are the coordinator for Ministry of Health for Medivac of severely ill kids. Implementation of AMS and IPC control in our hospital, why we consider that to be important, is that it helps us prevent the spreading of infectious diseases associated with antimicrobial resistance and also infections associated with healthcare. 1613, as well as Order 822 from the Minister of Health. These are the regulations that help us to develop the proper IPC culture. So what we started from, this is something that I would like to tell you about. The first step was that we identified the person that was the clinical pharmacist in the hospital that was responsible for the antimicrobial stewardship in our center. The responsible person, developed the 5-year plan, and he is now responsible to update it annually. The person was also responsible to introduce and conduct trainings dedicated to AMS, as well as clinical pathways. The clinical pathways, as well as the list of antimicrobials according to the AWARE classification, are being regularly, annually revised and updated. Probably you have all had a chance to learn that clinical pathways sometimes of your patients sometimes do not comply with the standard 1513. So what we did, we reviewed all of our clinical pathways, we reviewed and revised the requirements, and we found and indicated that all of them that include antibiotic therapy need to have 2 lines. Antibiotic line number 1, empiric therapy, and according to the standard, these are supposed to be the narrow-spectrum antibiotics that have a low potential for antimicrobial resistance development, and these are the lowest cost drugs usually. And line number 2 is the watch and reserve group antibiotics, which are supposed to be prescribed only according to the identified pathogen and susceptibility test results. According to the standard 1513, this is the order, we have introduced the written justification on antibiotic therapy prescription every 72 hours. So in order to relieve the work of clinical pharmacists, we decided to introduce this kind of a template, such a form for prescription of antimicrobials. So that has to indicate the date of prescription, the suspicion or identified disease, laboratory test results. That is important because I'm talking about complete blood count, procalcitonin, C-reactive protein that can help you really with prescription. The next column is international patented name of it. If you prescribe it as empirical or based on culture, the next date of revision. And if this is a reserve or watch group, then you need to get the approval from the clinical pharmacist. So this kind of a document is attached to the medical records of every patient. And if you have bacteriology laboratory results, you are supposed to attach those as well if you prescribe based on that. And you also are supposed to attach the pre-authorization form if you use the reserve group antibiotics. The next important component is cooperation with microbiological laboratory. In our facility, the bacteriology lab is fully automated, and they can interpret the results of pathogen identification, susceptibility and resistance over the period of 48 to 72 hours since 2022. Due to complete automation, it is for the second year we are capable to update the local monitoring of susceptibility data. That looks a bit different than the other colleagues have it. We include gram-positive and gram-negative only for the escape pathogenic group. Why it is color-based? This is because we want to make it more convenient for our physicians because they are overloaded with job. So we decided to use these like traffic lights. Green is everyone can use it. Yellow, it's a watch group, be careful. And red, logically, is a reserve group. And there is a fourth group, white one. These are the drugs which are not evidence-based. We also decided to include them additionally, and we cannot remove them from here because in some cases, with some pathogens, they are quite effective and they can help you save the life of patients. So using these evidence-based approaches, based on the laboratory test results, we can properly select for empirical treatment the best antimicrobial. This is because the laboratory provides us with the prevailing pathogen for each sample type. The next component is finding bacterial markers of inflammation. And my clinical case will tell you why it is so important for hematology department patients. This is a quite costly test, I have to say, and I will probably speak about that just a bit later. But when there is a patient, and we're talking about pediatric hospital, often the case we're using clinical judgment to make the first decisions. Kid with a fever needs to be examined, needs to be collected with blood sample. So you go for white blood cell formula, you go for sedimentation rate, procalcitonin, protein. Why it is important to identify the level of procalcitonin? Because this is a prohormone, which is highly sensitive and specific for bacterial infection. And depending on the concentration, we see the concentration grows proportionally to the severity of infectious process. That very much helps to identify and diagnose septic conditions from viral infection, and also to assess the effectiveness of your bacterial antibacterial therapy. The level of procalcitonin could be observed if it grows in about 6 to 12 hours. The increase in the levels of procalcitonin are not observed in case of viral or fungal infections, but you need to pay attention that there are some reasons that the procalcitonin may grow or drop down in blood, and that might be associated with the intake of glucocorticoids, glucocorticosteroids, iodine, immunosuppressive patients, and autoimmune patients. And a clinical case I would like to share with you. This is a hematology department. And here I want to show you why procalcitonin levels are important. A female, 15, acute lymphoblast leukosis, no information about remission. Indications for antimicrobial therapy prescription, in this case, was removal of a furuncle. She had a fever, pancytopenia after chemotherapy. She's got some hemodynamic disorders and stomatitis. She was collected with blood sample, urine and feces, as well as usually we start empirically from piperacillin tazobactam. This is a watch group, and that covers both gram-positives and gram-negatives. And piperacillin tazobactam, as of today, is cheaper than the reserve group drugs like meropenem, that covers gram-positive and gram-negatives. The assessment of patients with such conditions is done on every day basis, every 24 hours. And what we see here is that every 24 hours, 24, 48, we observe the increase in CRP and procalcitonin. And then as of 72nd hour, the CRP dropped down, but procalcitonin went up. That helped us to identify that the given antibiotic therapy was not effective in the patient. So after the identification of the pathogen, we found that the patient is a MRSA carrier, multi-drug resistant. So we changed the drug to vancomycin. And then we continued the assessment of condition of the patient every 24 hours. The next component is parenteral perioperational antibiotic prophylaxis. So before implementing this antibiotic prophylaxis, we had to look into the Order 376 decree from the Cabinet of Ministers dated 2023 on medical examination and test for MRSA carriage before surgical interventions. This is a nasal carriage. This is what we're talking about. Additionally to that standard, in order to make the work of a multidisciplinary team more convenient, which is composed not only of surgical staff for effective implementation, but also includes anesthesiology physicians as well as a leading pediatrician, we developed the peculiarities of all regimens of parenteral perioperational antibiotic prophylaxis. We came up with a dedicated table indicating what time before the intervention each kind of drug is supposed to be injected. If there is a complicated intervention, if there is a need for a repeated injection, what is the interval for that? And together with anesthesiology colleagues, we also came up with solutions, soluble materials for that, and also recommendations for combinations. And let me share another case with you. This is a specialized surgery clinic department. The hysterosoma was installed to a young male, 12 years old, cystic fibrosis and MRSA carriage. And main part of his life, usually such patient spent in the hospital, and they are in the risk zone, and therefore they need to be collected with a nasal sample for MRSA carriage. So he was found that he was a carrier of MRSA, multi-drug resistant. So how we prepared the patient for the intervention? 72% before, he was supposed to be conducted with eradication of his nasal cavities. The interval, the general duration of this eradication should be 5 days. It says that also according to the standard, he needs to be washed with a chlorhexidine, or his skin needs to be treated with a 2% chlorhexidine solution. Well, we actually don't have it available. So how do we manage such patients? 120 minutes before the surgical incision, we give vancomycin additional to cefazolin. So based on that approach, when introducing this perioperational antibiotic prophylaxis, we achieved the following figures. If we compare it to the year 2024, the reserve group dropped down to 1%. That was done at the cost of access group to the level of 88%. And the general figures for our center over the period of 2 years of this new approach implementation, we see the decrease in the reserve group drugs, but at the cost of access group, and it dropped down to 22%. And I don't go deep into conclusions because I already have enumerated them during my previous slides. Thank you very much indeed, colleagues. Well, thank you very much, everyone. Thank you very much, colleagues. We're done with the last presentation on this block. So traditionally, we're now supposed to have the questions and answers session. We have around half an hour period of time, so it's gonna give us like 2 questions to each of the speakers. And we'll start with Professor Hajtovic, I guess. Colleagues, don't forget to use the microphone, please. Thank you very much, everyone. Hello, colleagues. Oblast Regional CDC Center from Kyiv. Mykola, thank you very much for training conducted to the specialists of our center. That is very important to us. So the question is, very often we come across a situation when the medical directors in the hospital usually say it is enough to have 1 or 2 IPC specialists whom they consider to be responsible for everything. And then the AMS work is usually done by physicians in different departments. So my question is, do you think the stewardship coordinator, who is not a pharmacist, can in a qualified manner substitute or replace the clinical pharmacist in multi-profile inpatient hospitals in the field of retrospective, prospective audit, pharmacovigilance, because this is something that they also want to put on us as another role and responsibility? Thank you very much for this beautiful question. If I give you the answer the way it should be, it will take a lot of time. You understand that, right? But let me instead share our very negative experience when pharmacists were suggested to be replaced by pharmacovigilance, pharmacotherapeutic commission specialists. This happened some time ago when the clinical provisor was supposed to be the deputy head of the pharmacotherapeutic commission. Of course, he was supposed to be responsible for analysis, for procurement, for encoding and prescription of antimicrobials. At that time, there was a lot of resistance against the clinical pharmacists, so they decided to introduce one amendment to the order. They said clinical provisor or authorized specialist. That's it. So these authorized specialists were the chief medical nurse, and then amended saying like, well, higher education is required. And then the physicians started to do that. So now, when we collect the reports based on this formulary system, we see often the case that people responsible for that from hospitals, from regional commissions, pharmacotherapeutic commissions, often the case even do not realize what are they actually talking about. So doubtless, everyone should do the job he or she is supposed to do, according to your profile. So a physician, unfortunately, does not have time, does not have knowledge to do and to work with the molecules. And that's because it is not included on the educational curriculum. You're quite correct focusing on that. Number 2, the administration in the hospitals. And I touched upon that very briefly. And I'm grateful that the Lviv colleagues mentioned that they had a talk to their administration and they could see their jobs. They responded quickly enough. And they actually awarded the IPC department people, calling them to be the best one, to be the proud, that the hospital is proud of. Back in 2007, I want to give you an example. In the US, they have been actively introducing these AMS programs, and the first top step for them was this prospective audit with a feedback. And then later, the pediatrics journal published some results, and they said, well, the first top step that you need to make is to get administrative support from your administration. So you need to cooperate with your administration, and they must stick to the 1614 order requirements. Thank you very much indeed for this answer. One more question probably from the audience. Hello everyone, hello colleagues. Thank you very much for your very interesting presentations. Dnipro, Victoria Yanukova. I am the representative of the administration that you need to reach out. I also have to reach out to some people because in the IPC department we have only the head of this IPC department. And the situation that I come across, I used to have some young active physicians who wanted to learn the basics of this IPC work. So I contacted the educational facilities and I asked, can we get something like a specialization or method or like qualification upgrade or something? And it didn't work. So my kind of request or suggestion, can we get like a boot camp training or something, or like introductory course, especially in cases when the administration wants to do it. It can be like half of a decision, but we need to start from something, colleagues. Thank you very much indeed. Back in 2023, we created the technical recommendations on IMS and stewardship programs for physicians. For pharmacists, we have a different course. This is a 2-week course for physicians. We consider that to be quite enough. But it is not to replace the pharmacists. Please pay attention. This is for the sake of cooperation, proper cooperation. Thank you very much for understanding. And one more thing. Roman Kolesnik is, he's a very shy guy, probably sitting here, but he did what we couldn't do for about 30 years. This clinical pharmacy could not be implemented for like 30 years. We have been training people, but they were invisible at the level of hospitals. And then, due to support from Roman, he made it possible that the pharmacist can become the clinical pharmacist after postgraduate diploma specialization course. Well, and it happened. We trained about 20 clinical pharmacists like that, and we have 7 more who are going to graduate like in about 7 months from now. So, clinical pharmacists, it is a must. And the physicians, they need to know about the new trends, the novelties, and they should cooperate with them. Well, thank you very much indeed for that, because I just don't see the clinical pharmacists physically in our region. They just do not exist. Can I somehow contact you later on so that we could have a training course for them?
Since we have an area where we have to move into the shelter and stop the Congress for a bit, therefore we're moving into the shelter. Safety is more important. Thank you.
Продовжувати роботу.
Hey, colleagues, please come back.
Прошу всіх спікерів
We
наступного
are resuming our work. Please, all the speakers of the next fifth block, please take your seats in the panel.
Чудово, колеги, займаємо ваші місця. Пане Андрію, будь ласка, допоможіть закрити
Colleagues,
двері.
please come back. Andrei, please help us close the door. Let's continue our session. It is good to see everyone is back after the raid alert. I hope you had a chance to drink some coffee during that period of time. And I suggest we continue. This is block number 5, and the facilitator of this block is going to be my colleague, well-experienced specialist epidemiologist, not by her profile, but by her spirit, Maria Panasiuk. Thank you. Well, as a facilitator, let me introduce and give the floor to our first speaker, Ignat Gavrilo, and he will speak about the results of the strengthened epidemiological surveillance for antimicrobial resistance in wounded patients as a result of combat wound over the period of 2023 through 2025. Over to you, Ignat, please.
Ще раз всіх вітаю.
Hello, everyone. Hello once again. Colleagues, today we're going to speak a rather important and a very serious topic. I do understand that colleagues we have here in the audience and colleagues we have online, these are the people who are very much interested in this topic. These are people from IPC department, people from healthcare facilities who unfortunately on their own experience know very well what is war and how it looks like, what is care provided during the wartime, what is combat wounds, what are combat patients, and most probably majority of you have been involved or probably you see other colleagues involved in providing care and also reporting according to the order 403. This is what we will speak about today as well. So, strengthened surveillance for antimicrobial resistance over the pathogens that cause purulent, infectious and inflammatory conditions has been in place since 2023. And the big achievement is we came up with a system to be in place. We keep improving that, and we hope that in the future we will be able to use these achievements and this progress in order to collect even more information, in order to follow and monitor other pathogens. We will come up with the national level antibiograms. During the wartime, the big priority, of course, is given on the resistance among the wounded patients. It was September 2025 when we first published the accumulated data for the year 2024-2025, dedicated to epidemiological surveillance for AMR. You may use it, you may watch it, you may read it, you can share it with your colleagues, you can use it to talk to your administration, to your fellow colleagues. These are the national level data, evidence-based. And a bit of an update that we would like to share with you. We have some intermediate analysis data available for the first 3 quarters of 2025. They have not yet been presented. The report will be available around in a half-year period of time. We're still collecting some data, of course. What we would like to focus on, if we look now into the distribution of different biological materials, unfortunately, the situation with these different types, wound samples, blood samples, liquor samples, well, the situation is not improving, unfortunately. That is definitely associated with the lack of resources of your laboratories. There are some recommendations to be, very saving, especially when we talk about blood collection. That is not very good because you have high chances of losing or skipping bacteremia or improperly assigning a treatment in case of sepsis or other complicated cases. And unfortunately, the situation for the year 2025 says that the situation has not improved, though these are intermediate data. A rather interesting graph we can get if we do stratification of what microorganisms are more often isolated depending on the time of sampling. If we make it very simple, to the left, we see fresh wounds and fresh hospitalizations. To the right, this is a long-term care. Probably the patient has had many stages of evacuation at that point and has stayed in the hospital for a longer time. So we'll look into the different microorganisms, usually in the first place. These are the so-called escape microorganisms and two additional interesting ones in the end. You can see it here. The escape ones are interesting for us because they have the high potential to develop the resistance. These are often the so-called nosocomial pathogens that are epidemiologically most interesting because they're very dangerous. So the longer the patient stays in the stages of evacuation, the longer the patient stays in the hospital, the higher is the risk for cross-contamination or selection, drug-based selection for these pathogens, and they start to dominate during care provision. In case of fresh wounds, the portion would be every fifth patient like that, but during a long-term care, long-term treatment, Acinetobacter, Klebsiella pneumoniae, Staphylococcus aureus, Pseudomonas aeruginosa are the ones that really dominate, reaching up to 64.4% from the total number. Should we speak about the distribution of these microorganisms that are eligible for surveillance, I have to say that for a long time, during 2024, 2025, the Acinetobacter was the one that dominated. And everyone knows about that. But what is worth paying attention with regards to the trends and specificity is that there is a leader, and we see that this is the Staphylococcus aureus that is really moving forward really quickly. The data from 2023, 2024 demonstrated a steady trend. So over this year and a half, the portion of these Staphylococcus aureus is increasing, and the profile of resistance is getting more complicated. We have come to a certain consensus. We are quite afraid of the gram negatives. This is true. But unfortunately, I have to say, gram positives, well, represented by Staphylococcus aureus, they are also keeping up with that. They are also catching up, which is not good. Don't want to go deep into that, but let me briefly touch upon the profile and the percentage of antimicrobial resistant strains. Let's say Acinetobacter, one of the most common. And resistance here to carbapenems, aminoglycosides, is around 50–60%. What is interesting, the resistance rate is not growing, but if you compare it from 2023, 2024, you can see a slight, I would say, really slight decrease in that. It's too early to talk about that, but it is not getting worse, I could say. Regardless of that, the resistance profile is still very high. It is only the colistin that is still sensitive. It is still sensitive to that. But because of the specificity of use of this drug, you cannot say it's going to be used soon as an empirical treatment. Probably this is the case when the drug will help the majority of patients, but even to colistin, we start to observe that the resistance rates start to grow. And this is something to keep in mind as well. What else is interesting to look at? What is the resistance profile in different microorganisms depending on the time of sampling, time of detection? Well, a similar stratification based on time of sample collection. To the left, you see the fresh wounds. To the right, this is like a prolonged care provided to the patients. And it is not a secret, it is not a surprise, of course, that in the fresh wounds, when there is no selection in place, when the antimicrobials were provided for a shorter period of time, the sensitivity profile is better. But it is still pretty high, 30–40%, which means the probability is around 30-40%. Even if you prescribe meropenem or you give amikacin, you can still miss the right choice. That means even at the early stages of evacuation, you should not hope on a successful empiric therapy. Of course, we prescribe it, but in parallel, we must conduct bacteriological testing and we must take into account the test results.
Буде відбуватися селекція, і як ви бачите, вже
And the
приблизно
stronger the selection is, the longer they're in the hospital, and the twice-fold they increase in the resistance. So the longer, the worse, and the earlier we see the sensitivity and seeing the profile, then the more the chances are in safe treatment of the patient. Klebsiella pneumonia, a very, very unsafe strain that they're saying that they have high potential to the forming of resistance. And the resistance profile is enormous, especially like colistin is demonstrating some level of effectiveness, speaking about empiric prescription, but the same as Acinetobacter, unfortunately, the portion of the resistant strain is only growing. The E. coli situation is much better.
хіба що до пеніцилінів досить таки високий
Apart
рівень.
from penicillins, there's a high level of resistance, but this is not the best numbers in Europe, because we are hopefully that they are being better than Acinetobacter and others. So what do we like to stop upon is a SORLs. And so you see that you have more and more and more. And if we are saying that gram-negative, they have the big level of resistance, or maybe a bit reducing because of our efforts and your line of work. Then the SROs in some antimicrobials, for example, for quinolones or cephalosporins, the resistance is growing. And so what do we have to point our attention to? We see in red, which is the screening that we did on methicillin resistance.
Спостерігається сумна тенденція.
And so we observing a sad trend with the increase in the MRSA in the third quarter. We have the anti-record, which is 32% among those thousands of cultures of Staphylococcus aureus that have been treated in the military personnel. So the MRSA portion, almost every third Staphylococcus aureus, it's growing in number. The separate story is on the sensitivity to vancomycin, linezolid as well, because by going forward, this is under the, so I'm not a bacteriologist, I'm being sensitive in that most of the health facilities, unfortunately, are not following the correct methodology of the Staphylococcus aureus, which are those antimicrobials, because they have specifics. They're not deciding the diffusion methods that you all know, but microdilution methods. And unfortunately, they either lacking infrastructure or consumables, or maybe there are gaps in training. And so
Чутливість медалі, це ще повернемося. Але знову ж таки звертаємо увагу на те, що
but yet again, pointing your attention that the portion of SRLs is increasing and the portion of MRSA is increasing, but let's look at the adequate compared with Klebsiella resistance profiles, and you'll understand that and then Staphylococcus aureus, the question is in the IPC, because we saying that the spread of antimicrobial resistance, which is the factor antibiotic, if it's simplified, and then infection control and antibiotics against the SROs are still there.
Не буду сильно зупинятися на
And then not stopping in the other trend, and then compare it with the already published data so that we have enough time for the conclusions.
Посиленого епіднагляду, відповідно до наказу МОЗ.
Of the reinforced surveillance, then if the health facility, there is a lab, and that lab detected polyresistant strain, and it specifically says in which cases, what is the portion, has to be sent to the reference lab of the public health center for the future testing. And then what's also important is that apart from testing, and statistics collection, so that the colleagues from the bacteriology lab would, in cases of detection of any kind of false or positive results, they're going in contact with the health facility and they're providing feedback. And they're helping them solve this. So we are not just collecting statistics, and we're not just doing analytics, but we're also helping to correct some of the nuances and teach colleagues from the bacteriology lab from the regions. This is why this portion of reporting is really important. Not as everything is expected at most of the samples, which is Klebsiella pneumonia and Acinetobacter baumannii, because among them there's a lot of polio resistance and a big number of cases among them are being sent to the reference lab. In 2024, we observed, even then, they started to have observed this trend. We have an increasing number of these SROs, so there is a lot of MRSA started to be sent. And so now the situation, there's no interim data, but we are expecting it to grow. So what do we need to point your attention? So we have the data slightly mirrored. So what was mentioned in today's lecture. And so as we are speaking about the number of susceptible strains to the reference lab, detected polio-resistant strains, so they're already polio-resistant, the worst of the worst. And if we speak about the Klebsiella pneumonia, not everything is that, so that the resistance almost to everything, so that the small and susceptibility to colistin is still staying on around 90%. And we would just like to stop base here that colistin is a specific antibiotic. It's very expensive, and it's nephrotoxic in monotherapy. Colistin, it's not allowed to be used, maybe for saving purposes, or maybe they don't know or don't have a clinical pharmacist. Colistin is usually prescribed in low dosage, like 3 million or 5 million international units. This is insufficient dosing of antibiotic. This is a direct pathway to forming a resistance. Please read for the package insert for the manufacturer, then the daily dose is 9 million. Also use the punch dose of colistin in case needed, but it influences the quality of treatment. Colistin is a specific antibiotic. It demonstrates the effectiveness of against the gram-negative, but you need to learn how to correctly use it. So we are getting back to SROs, and on the previous slides, I mentioned that was the higher chances was suspected that for some reason the false negative susceptibility of to linezolid, it was confirmed by a reference lab. So even minimally, all of the samples of MRSA had to be sent, but we still observed in some of the cases susceptible to encephalocytin screening antibacterials, which means that even MRSA in singular cases were not wrong, were not correct, because let's look at the truly susceptible 98, 99%. So no matter how bad things are, MRSA, the empirically with vancomycin can be treated. And even though me as a pharmacist, I would like to highlight regarding the resistance profile and everything else, that you have the stage when MRSA could have treated with vancomycin, as I mentioned in my presentation by Dmitrov Kirillov. And so you're looking at the kidney function because it's toxic. But when possible, we know that the linezolid is the reserve group and vancomycin is the watch group. In the first vancomycin, then linezolid. And so taking into account the other statuses of the patient. So this is a story, but there are still questions. And so we need to check to what extent, how well acquired, and are there all the resources for quality detection of the SROs to vancomycin. Additionally, which kind of antimicrobials are being prescribed for the injured people after the military action? This is additional part to episurveillance that is being applied to. There's a third portion of the report, and it's well established that less and less cephalosporians of this third generation or fourth generation are being prescribed levofloxacin, mostly the access metronidazole or others. But this is a very specific question because it's great that
Але враховуючи, які полірезистентні
lesser resistant prone antibiotics are being given, but knowing how resistant the cultures are, we need to make bacteriology testing sooner to make the assessment of effectiveness of prescription sooner and possible to do the de-escalation. So it's okay to prescribe the wider spectrum antibiotics in case we suspect a complex polyresistant infection. But we need to remember that the antibiotic of the wider spectrum, impossible, you need to de-escalate.
І, власне, які рекомендації та
And
висновки
so what are the recommendations and conclusions
квартально передаються до
every quarter being given to the health departments, to health Ministry of Health, to the medical units of Ministry of Defense, and are supposed to be brought to the healthcare facilities. So right now we're speaking about the fulfillment as much as possible, the approved state standards. So we need to understand that it's impossible to standardize everything and to put everything as the Ministry of Health's order. So this is the nuances of the medical profession. So there's always a lot of the exclusion. If the standard covers 80 to 90% of some of the cases, and the war is not a routine story, then this is already great.
наскільки можливо, треба по максимуму
To the maximum extent as possible, we need to implement the IPC activities and rational use. And the medical specialists that are protecting to stay from infection, they are foreseen by the regular means. The Order Ministry of Health 17 number 77 and 16 number 1614 and 1513. So all those orders and standards, they were mentioned already. The question only is how frequently you're seeing the picture, and I'd like to mention. So when you can't fulfill everything from A to B, a standard or an order, usually they're saying no to all together. But when we are speaking about the infectious control, so implementation of the separate part, even comprehensively, some of the solutions connected with them, it can improve the situation. For example, if you don't have the ability to isolate every patient for multi-resistant, doesn't mean that you need to not wash your hands and not do anything. So then there has to be common sense playing a role because you saw how it happens. And then polyresistance microorganisms
найкраще, що ми можемо зробити,
are really hard to be treated. And what we can do is to decrease it in spread and to prevent them as much as possible. So this is the key thing. And in the context of the spread of the Staphylococcus aureus, let's not forget that this microorganism is well studied. There's many evidence-based sources, and also before the routine operation or like surgical in terms of orthopedics or cardiology, screening for SROs is being recommended for patients with the risk groups, which is the military personnel that have been hospitalized into the resuscitation units. And then you might have the routine, no screening, eradication, and the usage of 2% of chlorhexidine and pyritin. And so the practical moment, what we can also point our attention to, which is the buildup of the system on the stages of evacuation, because the situation usually happens, and the colleagues from the initial stages that have good bacteriology lab, they're saying that their patient are coming for a really short period of time and are given to the following stage. So they had the bacteriology testing, but the results are coming only after they've been discharged. And so it's a bad thing that when those results are not communicated and passed forward. We know about the results when the system is built, and this is even written in the 403 Order Ministry of Health, that you need to pass results forward. This is a big care about patient for the results to be passed on. And the communication has to be built. It's not written down. This can be in the messengers, this can be in the email, this can be a special number or the phone number of the attending physician, and so that the colleagues are present who will mention about this problem, that health facilities in the following stages of evacuation, even they're seeing the number, they're not calling. This is, I think, causes concern, and because I can't believe that don't care that much about the patient. So I think that this is the discommunication. So it's important for us to understand that the early stages of the facilities would give ability to contact them, and later stages of evacuation would be ready to be in contact with somebody, to be in one team, which is the specifics of care during war. It's a multi-stage care provision. It complicates both infectious control and the treatment of patient, and patient are specific. Therefore, we need to work as a team. So we are speaking with the teamwork of different departments in one hospital, but in the context of services provision to wounded patients, many different facilities in the same stage of evacuation is supposed to build horizontal communications. Therefore, colleagues, the last thing that I wanted to mention, and then the IPC activities especially, and then to implement this is a very complex thing to do, and so it's not easy to do in a peaceful time, but we are making something very important because we see with what kind of microorganisms we have to deal with and how to do that. The orders have been mentioned, but the orders usually it's dry. They're just a legally correct language, and Public Health Center and other partners organization are helping us in conducting trainings. And so in this webpage, there are some materials that Public Health Center has. This is free of charge resource. We have a Facebook page as well where we are announcing events, and so the YouTube channel where there is a broadened library that's constantly updated with the trainings and webinars. Therefore, I welcome everybody to sign up, to familiarize with the materials, depending on your area of interest, and to use that in your work. And we know that it's hard, but you're doing great, everything possible. And then we are doing this because, as the Haley already mentioned, what is our internal motivation? We want to help the patients. And I'm sure that we will be able to manage it. Thank you so much.
Пане Ігнате, дуже дякую за таку дійсно цікаву, інформативну і мотивуючу доповідь.
Thank you for this motivating, and I will be welcoming the floor following speaker, which is Anastasia Zhevko, specialist in strategic information and epidemiology of the ICOP in Ukraine. And also Anastasia can share the presentation and the experience of the initial experience in Ukraine and implementation of the screening on the colonization of carbon-resistant microorganisms, and also the merger of health facility to the international network of the epidemiological surveillance on the category of pathogen green art.
Так, доброго дня, шановні колеги.
Greetings, dear colleagues. So happy to be present here today with you all. And I'm so happy to share our initial experience. I would just like to highlight that this is our initial experience. This is still ongoing. The insights of the insights. This is the first part finished recently, just a week or two ago. And my name is Anastasia Zhevko, and I'm the strategic information and epidemiology expert from ICAP. And so we can start with the short overview on what I'll be mentioning, that you've seen the whole logic of the presentation. A few words why this issue is present in Ukraine, so why this is critically important, why colonization. And then I shortly explain what is the GAINAR system, and we will mention a few things about that today. And after that, I will tell you about the design of the research, of the observation, so why the 24 hours were being selected, so why the first stage was done as a PPS, and then the first stop will be made on methodology of the observation of like how the screening was made, what was done, what was tested, who was tested, and then after that, I will show you the preliminary interpretation of the results. So nobody's seen this analysis or data. So why did we start from these numbers and make extrapolation so that to do this observation later on? So I think that I don't have to mention one again. So we know that the burden of the AMR in Ukraine and overall in the world, but we all understand like what is the situation in Ukraine, so that this is complicates with everything that the healthcare system in Ukraine is working in conditions of war. And this changes patient pathways, increases the load to the inpatient conditions, it creates additional load to medical personnel and to our health system altogether. So I think you know that there's an ECDC materials, and when we're speaking about colonization, carbapenem-resistant microorganisms, it's important to remember that this is not our like local idea. This is recommendations that were given to by other international partners in the beginning of the full-scale invasion. So right now you can see on the screen, this is the report from the 8th of March of 2022 at the beginning of the full-scale invasion. ECDC has published a technical report on that the countries of the European Union has to include the higher risk of multi-resistant microorganisms among people that are coming from Ukraine to the treatment in Europe. To the European health facilities, been given a recommendation if the patient had a hospitalization in the past 12 months, then he has to be isolated and to be tested for multi-resistant pathogens. And a separate part was mentioned that this is the need to check for the carbapenem-resistant microorganisms. So for us to be speaking in the same language, I would just like to mention that what is screening, and then when I'm saying screening, what I mean is not the treatment, I mean not the diagnostics of patients, but search of people who might be colonized. So the screening is active screening is like active search for patients. And so we're checking everybody in the specific groups, independently what are the symptoms, to find the ones who might be a carrier. And for the carbapenem-resistant microorganisms, this is critically important because most of such patients, they don't have specially selected symptoms and they are unsafe, and so they might be a source of the transmission of infection into the hospital. As for the medical personnel and for the patient throughout the health facility. Screening, if shortly, screening is needed not because for like a process or something else, but for the safety of the patients and the prevention of future outbreaks in the health facility. So there are specific objectives. The first objective is early detection of carriers. If you want to find as early as possible the carrier, not to allow the transmission in all of the hospital. So early detection would help you to disrupt this chain of transmission. The second objective is identification of the patient to understand like who has to be isolated or to use contact means of protection, so that the screening can help you understand like who needs a reinforced means of protection. So without that, if this is not implemented, we will be unassessed, we will have unassessed risks, or we can overload the system altogether with the unwanted or unneeded isolation in the health facility. The third objective, which is the monitoring of effectiveness of activity and prevention of infection and IPCO together. If preliminary, we can see if our facilities or activities are working, if the level of colonization is decreasing, then we are moving in the correct direction. If not, then we need to correct something somewhere, and we need to understand like where something is not working. The fourth objective is the understanding of the epidemiological situation that is happening in the health facility. And the objective number 5, which is really important, the screening might help you with that to detect new or pun-resistant new mechanisms. And so what is the carbapenem-resistant organisms, or CRO? That this is the gram-negative bacteria that are not they're not susceptible to carbapenem anymore. Carbapenems were, I don't know how can I mention that this was the last line of defense when other antibiotics are not working. Therefore, then the bacteria is resistant to carbapenems, and then the treatment options are really restricted to the patients. So why it's important to understand these 3 different conditions: contamination, We all understand that the bacteria got onto a person but didn't grow or didn't stay there. Colonization, which is bacteria is there, there's no symptoms, but there is a risk on this stage is already very high. And the infection is when there is a clinical manifestation and then the treatment is needed. So here the objective is to detect this infection on the stage of colonization when the clinical symptoms are not yet there, and we can prevent the spread of all of this within the health facility, because we understand that we have other patients that are might be more complex, or the situation is maybe have another organism working there. So we are trying to protect the hospital from within. So I really like this slide, and I picked it from our colleagues from the CDC. This idea, it's well seen why colonization is so important. So the infection is just the tip of the iceberg. The main masses of problem are still with the colonization, and we don't see it, which is the fact that on this stage, the patients are asymptomatic. We don't know what is happening with the patient. So this is the main source of transmission. And this is the example of the modeling, and information was provided by the CDC. Just a few of the numbers, like how can this work? This is a very simple or easy to understand the risk modeling example. If among the 100 people, 80% will be colonized, then in 30 days, we can inspect for around 15 infections. And so if this is the calculation, if we are reducing the level of colonization to 20 people from 80, then there's going to be much fewer infections. And it's going to be difference minus 11 infections in a month. This model is showing the general principle. So why are you doing all of that? To decrease this hidden portion of the colonized, we don't need to wait for when the infection will come. We will be detecting them prior to that. And also why this is important. First of all, the bacteria, they're causing infection with the very high level of mortality, especially in the complex patient, for example, like in ER. And we have a lot of military personnel, a lot of, you all know better than I do, their status, the patients are preliminary. Somebody of the presenters said about the burn department, where the situation is really complex. And the second thing, the strains are almost non-susceptible to anything, to no antibiotics. The third thing, carbapenems and antibiotics, as I previously mentioned, that it's a last reserve antibiotics, and when there is resistance to them, this is already too complex, and this is becoming really, really hard to treat them. Then the colonized patient that don't have any symptoms, they're really unsafe for others, or pose danger. So now let me tell you about the methodology, and so I familiarize yourself so that you would understand like what I will be telling you all. So there is this global action and healthcare network. It's a whole network of partners. It's GAINR. It's a global action and healthcare network that is working on different levels, from the countries to separate hospitals. The point of this network in rapid detection, prevention, and response to infections in health facilities. GAIN, this network, it's integrated into the laboratory network of CDC from the antimicrobial resistance. So this is not like a separate initiative. This is the portion of a bigger world system. So there is a separate two modules. The first, which is the infection during healthcare services provision. And then the second one, which is GAIN-R, that I mentioned to you before.
This information was provided to us from the CDC Center. We're not yet at the implementation stage. We are now at the stage of understanding of how it may work and how it may be feasible to implement in Ukraine. These are the results of implementation from some other countries. starting from 2021 through 2023 in 14 hospitals. More than 2,200 CROs have been found. More than 1,200 samples have been tested for carbapenemase. 600 CRO have been confirmed. Sorry. A big massive of data, so to say, that allows for decision-making. 16 laboratories during this period of time obtained additional diagnostic capabilities. 8 of them do it regularly now, I mean the CRO screening, and 4 more started to identify these carbapenimases because there were many laboratories that never did it before. To my mind, that is a big progress in diagnostics. The goal. I talked about 3 components to the system: prevention, detection, and response. So the strategy is going to be very much focused on these 3 components. Prevention, more specifically improvement of quality of prevention. Speaking about hand hygiene, contact precautions, isolation. So whenever there is a higher risk for transmission. Detection. Clinical and reference laboratories cooperate together so that they could detect, provide characteristics to any critical or new pathogens, and ensure the proper and timely response. And response, the 3rd component, we of course do that for some purpose. So the strategy covers the actions and activities that take place after the laboratory test results, after some critical situations or some new pathogens have been found, and of course the critical focus is given to the carbapenem-resistant organisms. So let's briefly discuss what has been done in Ukraine. Let's briefly talk about that. You can see here the protocol, this GAIN-R protocol. This is the international protocol I told you about. We use that for our purposes. So the screening we conducted was not just a one-time initiative, but that is something that has been done within the current epidemiological surveillance protocol. That one complies very much with the global network core principles. It was adapted for the Ukrainian purposes, and an important detail of that is that it definitely was adopted. It was approved by the Ethics Committee at the Ukrainian Public Health Center and also the Ethics Commission at the Columbian University, US, which means all the processes, starting from sample collection, data processing, cooperation with patients, they all comply with the national ethics requirements, and they could be used in Ukraine. After I mentioned we have approved the protocol, let me briefly remind you, colleagues, that at the given stage it is important to distinguish 2 things: epidemiological surveillance and epidemiological study. We're not talking about study in this case, we're talking about surveillance. Our purpose was to constantly keep an eye on the situation, to monitor the situation. Study is different. It is usually conducted with a certain hypothesis. There are some research and scientific conclusions focused on some scientific problem. It is usually limited in time. In our case, we wanted to have it continuously. This is what differs the surveillance from a study. The protocol. This is what has already been done in Ukraine, just for you to know. So we have clearly identified the goal of the protocol for surveillance. We have identified and came up with a design and the population, the group of patients, and we definitely wanted to understand what are the capacities of the healthcare facilities to prevent, detect, and respond to threats associated with AMR resistance, more specifically with CRO. And designed to that was the active surveillance measures for CRO by means of testing, providing screening for colonization among patients that have been admitted for inpatient treatment. And we conducted that in the participating hospitals. Let me briefly tell you about the general situation. We use the GAIN-R standard protocol. All the patients have been tested in the department by means of rectal swab for carbapenem-resistant organisms. The first one is considered to be the baseline screening. And let me tell you what has been done as of now. Just a week ago, we finalized the so-called basic or baseline screening. Then this kind of work will be continued. Once we launch it in a fully fledged scale, so to say, we're going to have more results. So if the first swab result was negative, then the patients were supposed to be retested at the discharge day or transfer day. That enables us to understand if the colonization took place inside the hospital, in the department, and where do we actually have this problem with the patient colonization. And the third component to this whole protocol is prevention of transmission. So we can see a certain picture at the moment, we can see the certain pathway to the given patient, and that gives us the understanding how we can respond to that and how we can control that. The methodology. Let me briefly explain how it worked. You remember I told you that sample collection is conducted in patients at the admission and discharge stage. After that, during that, it is not any separate. We also collect the demographic data about the patient. We also transfer this data to the Red Cap. This is the software system. The main server of that stays in the UPHC. They use the laboratory method. This is a direct culture, McConkey culture. Then, once the work is done on behalf of the laboratory and IPC department, and the data is on the software, you can analyze the situation now and you can see where it all comes from. So, what has been done as of now in Ukraine? We have conducted, as of now, 24-hour surveillance within this active CRO surveillance framework. We have included 4 hospitals into that process that provide care to wounded patients. And there are patients not only who are not only the military wounded servicemen. With the hospitals, we have identified 2 departments with the highest risk. These were usually trauma, surgical departments, ICU. No, that's it. Urology. Yeah, someone is telling me urology. Exactly. Thank you. So we provide so we included those that were wounded as a result of warfare and those that were not wounded as a warfare. This is how the algorithm looked like. The PPS for PPS, it was conducted within the time frame from the 21st of October through November 6th. It took 1 day for a department. So we would cover all the patients available or admitted to the given department. All of them have been provided with a colonization screening. We used the paper documents. Initially, we registered all the patients on paper registers. And sorry, I skipped one thing, which is very important for analytical part. The patients I'm talking about, we did not sign the information consent form with the patients. This is a very important part, which I forgot to mention. We have inclusion and exclusion criteria for patients. So whenever you come to the department, you see all the patients, and we would collect the samples from the following patients. The ones that in their medical records, in their history, current or previous, did not have infection registered. So we would open the medical records and we could see like, okay, the patient already has an infection. We did not test such kind of patients. We did not screen them because they were excluded according to the criteria. And then we would include the patients who did not have a registered infection on their medical records. And then we would inform patients about that, of course. There is a whole procedure for that. We trained the medical staff to do that. And then the medical nurse or the physician would inform the patient saying like, you will be conducted with a screening like that. And probably your colleagues know, if you work in the hospital, when the patient is admitted to the hospital, they're supposed to sign a 003 form, if I'm not mistaken, saying that the patient agrees to participate in all the necessary testing and other activities. So it was done within the given framework, but there was a chance for the patient to refuse if the patient did not want to participate. There was always a chance to do that. I will share some figures, and it's interesting to look into that a bit later. So we would talk to patients, explaining like what is the sample, how it will be collected. So if the patient says yes or they refuse, we could still have a chance to talk to the patient later during the day if the patient refused, trying to persuade. So the patients who agreed, we would collect samples from them, of course. Preliminary results. What has been found? So the total number of patients included was 209. These are the patients whom we found. Please pay attention. There was a certain number of patients with known or previous CRO infection. 18 out of them. So we could see 18 out of them were already resistant. So that means we had 191 patients without previous CRO infection. Out of them, 157 agreed to participate in the screening and 34 refused. To my mind, and Maria, correct me if I'm wrong, when we all started that, we were afraid that there are going to be lots of refusals. Someone told them, told colleagues, like, imagine if somebody comes and says, like, let's collect a rectal swab from you. But patients were okay with that. The physicians were very nervous about that because they thought, like, well, probably the patients would refuse. But in many cases, and we speak about different departments, of course, the majority of cases that refused were only the severe patient that, you know, were conducted with lots of interventions and they just didn't want to have another one. So the previous results, 18, as I mentioned, were patients with known infection, 8.6 of the total. Patients that were included into surveillance activities, which did not have previous infection, 191. 34 patients refused to participate, and the total number of patients that underwent the screening was 157. And now, probably the most interesting part, now I can say it. I can say it now. The last but one slide is really the most interesting, I guess. So what was the situation that we observed? The patients, you remember, that were collected and tested, 157. Out of them, 32, meaning 20% of the total, and were positive, CRO positive. You remember the situation with the carbapenem-resistant patients provided by Ignat in the previous day. And that is a very high percentage. Not high, somebody says, but this is the preliminary data, preliminary results. 20% is actually a very high percent, is a very high figure. So if we're talking about patients with colonization and infection, and you add those that have already known infection, the total will be 28%. Let me speak briefly about some conclusions. Colleagues, this is the first stage. This is the baseline, as we talked about that. In the future, we plan to have a wider screening to be conducted. We just double-checked some things. We tested and piloted some things like communication-related aspects and stuff like that during this first attempt. So this is a first pilot surveillance like that among hospitalized patients. The data about this prevalence demonstrate that colonization is actually much wider than we thought, than the number of clinically confirmed infections. Number two, we see that the patients that have there is a large amount of patients that have a threat from that CRO. That yet again underlines the importance of basic IPC routine actions. I know that everyone has a very high workload now, everyone working in the healthcare system. And not all of you in the facilities have a chance to isolate the patient. You just do not have premises, you don't have rooms for that. We realize that. But we need to figure out, we need to find a way how to tackle this situation. Ideally, in a perfect world, we would like to have a dedicated room for isolation for every patient like that, but we understand that is totally unrealistic. Some more things, some more issues we will work upon and we will think about. And we will analyze the data for that purpose. We want to understand better how can we integrate these suggestions into the Ukrainian reality. We need to understand how this additional colonization screening to better investigate this transmission, this admission and discharge screenings, and how can we strengthen the routine clinical bacteriology tests so that we could improve the diagnostics in general in the hospital. Colleagues, briefly from my side, thank you. This is it. No, don't be in a hurry to ask questions. It's a bit too early. Sorry, we still have a couple of speakers in the given block. And the next speaker is going to be me, Maria Panasiuk, the clinical specialist for ICAP, from ICAP in Ukraine. My speech is going to be a bit shorter, but I will speak about similarly important issues. Just as Anastasia mentioned, the big part of her presentation and presentation of many other colleagues, they actually underlined the importance of IMR resistance for Ukraine and for the global level in general. And that definitely means we need to somehow respond to that problem this way or another. So, colleagues, what I suggest we do now, I suggest we speak briefly about response approaches. When we detect a pathogen, let's say the laboratory has done the testing and the report comes back to the department or comes back to the IPC people, IPC department. And just as my colleagues and Ms. Anastasia mentioned in her presentation, this kind of activities will be related not only to infected, but also to colonized patients. So here we're talking about IPC measures, contact precautions. this is something that the IPC department people have to implement in the department as a response action. This is the very local, this is the closest level, so to say, around the patient. And then the process includes AMS, epidemiological surveillance for this category of pathogens, cooperation with other departments and stuff like that. In order to organize this work for response activities to detect these mechanisms once we obtained the laboratory test results, we cooperated with 3 rather large-sized hospitals so that we could implement this process. I mean, this response process and actions focused on IPC development, SPC actions development, making sure that there is proper communication inside the departments and in between the departments, as well as training to medical staff. The first thing we came across was resistance, not microorganism resistance, but the system resistance, the system rigidity. People were not very happy to change, were not very happy to adopt to the new requirements. So in order to implement these changes and to overcome this resistance in the hospitals, we used the so-called an approach which is called the quality improvement model, which is composed of several mandatory stages. Number 1 is you need to identify the goal. What is the purpose of that? What do you want to achieve? You also would like to develop certain, or make sure you have some tools to measure if this goal, if this purpose could be achieved. And you want to measure it regularly. As a result of that, you want to conduct a certain analysis based on the data obtained, and then you want to adapt, you want to implement changes, given the context of every specific hospital. So the general goal of the project was definitely to cover the needs of every hospital, but then every hospital would have their own objectives, their own goals. That means we use some additional tools for that, like the tree of decisions, the tree of solutions, because every hospital had to work upon some barriers, upon some issues from their own side, and they also suggested their tree of solutions for that. Many things were similar, because I have to say, well, we are working in the same system, and the ideas of change most common for all hospitals were associated with training of medical staff, theory and practice of PPE use, as well as provision of feedback following the second stage of monitoring activities. So, in other words, we train the staff to do something, and then we need to collect the feedback, and we need to ensure the monitoring if they do it in a proper way. In order to assess the effectiveness of these implementations, we used the so-called PDSA cycle. Each idea, each implementation was supposed not only to be implemented, but was supposed to go through all of these cycles. And the first is definitely dedicated to problem analysis. For that purpose, we have developed a certain SOP, which later helped us to come up with contact precautions, with monitoring tools, and different kinds of checklists and things that could be used. And this is something that we will demonstrate to you. All of that has been done at the preparatory part. Then, during the second stage, we are supposed to, perform the plan. We are supposed to implement the activities. We need to document, collect data, ensure monitoring. Then, during the next part of this cycle were supposed to do the data interpretation, analysis, some kind of summary, conclusions. And we need to understand if that was effective. If it was not effective, what can we do differently? And during the next part, we have to adopt, we have either to accept it or we have to refute it and go for the next cycle. So this kind of approach was used, and this work lasted for about 3 months. And the overall goal at the level of the project was to improve the implementation of the contact precautions based on the bacteriological surveillance data for MDRO in the 3 given hospitals. Each hospital had additional sub-goals depending on their specific local problems. So in order to measure the effectiveness of achievement of this goal, if we achieved it or not, we have had a list of indicators. Of course, number 1 was the coverage of patients with the contact precaution measures, if they have been identified with the target pathogens. We also looked into the available infrastructure. We also looked into compliance of medical staff, how to what extent they complied with the requirements to contact precautions, to hand hygiene. And we also looked into the interval of time between the MDRO detection to the contact precautions implementation. At the preparatory stage, I already told you, we looked into we included the idea that any quality improvement any quality improvement project means you have to stick to a certain standard, because compliance or incompliance to a certain standard well, implies you need to have that standard at hand, because you want to use it as a certain beacon. Therefore, we have developed the SOP that in a maximum detailed manner described this response process, identifying what the medical staff is supposed to do and how, so that we wanted to use it as a beacon for this quality improvement. So the contact precautions, well, they have been outlined pretty well in the 1777 order, but in what cases are we supposed to apply it? For the sake of what pathogens? So we decided to come up with a list of microorganisms, of pathogens, which is based on this 1777 order. All of them are included into the given order. So these 5 pathogens, and they also, I have to say, comply very much with the international recommendations from American CDC and ECDC. And please pay attention. To us, it is not the threat of the pathogens per se, I would say, but we're talking about pathogens that are gonna be problematic from the point of view of treatment in patients with a certain resistance profile. Because Klebsiella, if it is sensitive, it's not a big threat, right? You know how to treat it, you know how to behave, you know how to keep to these aseptic or antiseptic rules. But when you come across a microorganism with a specific resistance profile that causes additional problems in treatment of the patients, that poses additional risks, threat, that have high probability, have high potential for intra-hospital outbreaks, nosocomial outbreaks, well, that is something that you need to take into account. You need to respond to that, and you need to be able to respond to detection of such pathogens. So additional block has been added based on the international recommendations. This is a block of microorganisms with resistance to carbapenems. And here we talk about both colonized and infected patients. And you can see the list of those below. So what was supposed to happen after the microorganism like that is detected in the department, when the IPC department or the physician get information about that? Well, they're supposed to introduce some contact precautions. I think it's not a novelty to you, colleagues, because this is really some brief information, like really in a nutshell, what is included. And this is what we used for the sake of our quality improvement projects. Number one, in this case, isolation or source control, well, meaning the patient isolation. And here I have to say that we see quite a number of different discussions currently happening because we have very many patients like that. So the discussion is about how can we implement that? Because I think now on the audience we have like 50-50 ratio. Some did it in their hospitals. The others are still thinking like, how can we do that? Because we're limited in space, in everything. And we cannot probably, allocate all the patients. We have like not enough premises again. We can't put them in the corridors. So this is why I say that is very important. Cohort isolation is possible in the bigger room with compliance to certain requirements, like at least 1 meter between the beds, the use of medical curtains, and also additional actions like hand hygiene, use of PPE, disinfection of surrounding area. And the PPE should not only be used, they need to be used in a proper manner, in a proper place, in a proper time. That means they need to be properly located, not just elsewhere, everywhere, but in a proper place, not in the stock, not in the storage, but at the entrance to the room of the patient, not inside, but at the entrance to the room with the isolated patient or cohort isolation room.
If it's a head of the reanimation department, you only have isolated just one patient in the whole room. So this has to be before the patient. And so this has to be discharged from the zone of the discharge of the patient. So that regarding the disinfection of the surface, that there has to be clean, the high contact has to be clean 2 times a day. In the wards where there are isolated patients are being located. And the last thing is that it's either the use of the individual equipment, which is impossible, and the use of the express disinfection of equipment that is being used but not critical one for in the health facility. And so the next thing that I would just like to share, which is to implement the contact means it's possible, because to be sure, we still had our doubts about that. So as we mentioned by the previous speakers, and especially yesterday, the motivation and the line work of the IPC department, it's providing success stories, and you can counter any kind of gaps in the areas. This is why this is just a good example of how can be organized when there's really an entryway into the ward and there is specific marking that here we have an unsafe area, so why this is unsafe and what specifically has to be done by the medical worker by entering into this area of care to this patient. And so the placement of all the needed PPEs before the entry into the patient room. This is just as an example. Every department will have their own situation, but it's supposed to look like this mostly. So what is absent here, there's no bin because it's inside of the board. And then there was the most interesting part, which was how to organize this. This is one part of the issue, but then to teach medical personnel to use this correctly, and medical nurses, and then the junior medical nurses to follow those recommendations to correctly take off and take on PPEs and to access both of those important moments, how to organize this and whether the medical workers will be following it, because one without another will not work. Checklist has been developed. It helped us to measure our indicators and to understand what specifically the problem is. This is a checklist that is following the contact protection activities that have 12 points that are covering the main key target parts that has to be fulfilled by the medical worker by entering into the ward where the patient is isolated. So this is hand hygiene. This is the usage of PPEs. It's not that just that they use PPEs or not, and how they were used, whether they were correctly taking on and correctly taking off, and whether the hand hygiene has been conducted, and so the last processing of the hands for the PPEs. So non-critical equipment, whether the PPEs were present for the and means to disinfection or the zone for the use of the dirty equipment, and the option for patients that are located for a multi-place ward is the medical worker supported in their processing the hands, and if they're wearing the PPEs, are they changing the PPEs in the patient? And so you can assess the following of this checklist, taking into account the percentage. And then you can calculate the percentage on the horizontal as well to understand like what specific options do we have an issue and how comes. And so this is when you can assess and adapt the training facilities. So somebody has PPEs, but the medical personnel do not know how to take them on, taking it off. And then we need to learn how to wear them. Somewhere, because of the checklist, they found out that the department has a deficit of PPEs, and medical personnel maybe know how to wear them, but there's not sufficient amount of PPEs, for example. And out of that specific experience, the biggest issue is just processing of non-critical equipment, which was the hardest to organize, and then was what that was hardest to work. The second checklist has been regarding the organization of the space for the following of the isolation requirements. So if the marking is present, if the PPEs are present, and if they are located in the correct place and before the entry into the ward, so that the alcohol containing antiseptics, and then cleaning solutions for the critical equipment. The type of isolation, if this is not a cohort isolation, but the multiple rooms of the patient, are there any conditions that we can say that this is really an isolation of just the patient's state with others? Do you beg your pardon? And in that way, we could have calculated the general percentage of following. And on the horizontal pathway was what specifically the issue is connected with that specific department. And shortly, let's not touch based upon the results for too long, because every facility has their own situation, has their own issues. And in the health facility, there's a few pilot departments that has been included. So I think that the most interesting part in all of this are the checklists themselves and trying to try them at a specific practice in their own hospital. But we can see that in general, that this approach has turned out to be effective, and that in any case, no matter how much observation would be conducted from, and then it will also, depending on the number of patients with the MRSA, and so that their progress has been there, and also how things were processed and how medical personnel are following them or not. The methodology has recommended itself as effective. And so the last stage that I promise will not be taking too long. So the next stage is when we assess the structure, how this is processed, assess the behavior of the, and we just need to assess the general result. And for those two indicators that we mentioned before, the coverage, if all the patients are covered with those microorganisms, and how fast as the IPC department can detect. And so with that objective, we have developed the Excel table that turned out to be effective and helped us not to only measure our indicators, but also to work for us as a good instrument for the episurveillance over the antimicrobial resistance. And so just a few words about the results on our indicators. So on the coverage of the patient, the result was very good, and independently on what facilities have started off of, then the end of this third month, almost 100% of the patient has been covered. by the contact activities and the measures. So sometimes they might have gaps. Some were medical workers didn't do something correctly, but and then they were covered as much as possible. And then the results of the allocated, so they have good results because for during the basic level before the beginning of that, we saw that in some of the hospitals from the bacteriology lab before the contact facilities are done is around 2 days. So a day or two is so when the process has started, and then the Department of Infectious Control and they started to communicate together and give the information to in effective way. This was in effective ways on the emails, or this was depending on digitalization of that or another health facility. And then the information started to get not only to the IPC department but also there, and so we were able to reach that the health facility health activities has been implemented to 2 hours from the results. So I think that this is the enormously great. So why there's not a third one? Because the third facility was not able to measure this, but this is all in the future. So I would just like to get back into this instrument because even yesterday and today we mentioned about the matter of episurveillance on AMR and everything else. And so if we have the instruments for episurveillance on HAIs and they're approved by an order, maybe they're not perfect for some reason, and so we are continuing to do the work. But on the episurveillance on AMR, then we don't have approved instruments on that. Some of the hospitals were using
Хунет, я хотіла
Hunet,
сказати.
and some of them are using the labs that have this apps or this. They are uploading the data and then they're giving it to the epidemiologist, where it's the Hunet is not implemented. This kind of episurveillance might not be conducted because the form for the analysis where this data continues to be given, they're just not there. And therefore, for our 3 facilities that we had worked on, we have developed such an instrument. It has recommended as effective, and I can propose this to you as the thing that you can base your work upon or to adapt to your needs. And so what is important here, this is the minimal information that would be needed for the analysis of the situation and the antimicrobial resistance, which is number of medical card of the epi patient, then the number of the department where this has happened, the place, the date of income, because we need to know when the date of the income and then date of the discharge or the sample taken. So those 2 dates has to be there. Type of the material, so what did we sample, and then in the future you can also add the graph if it's the clinical sample or this is the screening testing as well. The date of the result given, so that to track how fast we were able to implement the contact means of what kind of pathogens is here. Speaking about the pathogens, we're not just interested in the pathogen, and pathogens was the specific profile of the resistance. And so the note about isolation, type of the isolation, the date of the implementation of the contact means and student to which day of the stay of the patient they have been implemented. So this is the instrument that can add to the episurveillance on the HAIs, because we understand that we need to respond not only to the specific cases of HAIs, but also on the situation when the patients without HAIs with their main conditions, they would have microorganisms with microbial resistance. So I think that this is can make your work much more effective, easy to do, and the process for medical services provision for patients to be simplified a lot. So I think that this is possible. And then I'm not going to touch based upon here on the conclusions, but the first thing I wanted to mention that the model of improvement of quality, and he recommended itself as an effective one, and then the implementation itself of the new intervention in the IPC through the PDSA cycle, it was effective, and this instrument might be effective in the IPC department implementation. And then the usage of those checklists can also be not happening not only within the project, but also within the your routine practice from the emergency response to the AMR, and then the effective response in the room has to add to all of the other activities on the HAIs. And thank you all so much for your attention. And then we will have the time for questions and answers. But right now, we'll like to welcome the following speaker, Olena Bachenska, the head of the Department of IPC of the Medical Center Medicap, was the presentation dynamics of the spectrum of susceptibility to antimicrobials in the hospital of pneumonias. Thank you so much.
Дякую, Марія. Хочу перш за все подякувати
I
за
would like to say thank you for an ability to participate in such a wonderful, very important event, and to say thank you to the Public Health Center's team for which is the young, talented, energetic,
безстрашні, які
so fearless, the ones that are dealing with anything. So the young people, and I would just like to say thank you for your line of work, because for me, I have a lot of things to study and learn from you. You're just doing great. Thank you so much.
Я хочу поділитись досвідом динамічного спостереження за
And the dynamic processing and observation in the health facility, this is not a long period of time, but I think that this is even better because it allows us to concentrate on the issues on the health facility. And also it's a private facilities, and therefore it's much easier to implement the means for infection prevention in IPC. And I would also like to highlight this very important aspect that it's really hard to implement in the state facilities, which is the principles for many years ago, when during the admission of patients, they replaced the clothes, washed the body. So this colonization that today and yesterday we all were speaking about, that really is very widely spread among the patients that are coming in, especially in the urgent indications. This is the different level of culture of people. This is the different social status. This is different skills. So we saw many different people that with such unfortunate cases are coming to the health facilities. And of course, that those colonized patients, it's an issue because you've seen that there have been the results of the study that Anastasia has presented, that this is every fifth patient that they're not of advanced age, probably they're not from the risk group. That we see that 16, 14 in that order, that where we are looking for the risk group patient that might be colonized already, and we are stratifying them in accordance to the 1513 order that can be possibly having the HAIs or another infection. But those are regular people. What does it tell us? That this issue is widely spread in our space, an epidemiological space, essentially, because the epidemic process, this is the continuous process, and you can understand that the pathogen is not asking anybody if he wants to survive. It evolves, and so you need to understand that your episurveillance, this is the system that is working day and night, and then that we have to be always in contact, always. Then it's the state of immunity. So we all know about the persistence of the, so they can persist. And also I would just like to highlight your attention that those pathogens that are colonizing the surfaces of the body, it's either undertreated, not eliminated infections, or this is specificity of phagocytosis, not finished phagocytosis, and so there is the effects of the immunity levels depending on the outbreak or patient or pathogens is being developed. And so by understanding that each and every pathogen is specific, but we are working with the regular pathogens as well, the ones that we thought that was a saprophyte flora, or the ones that were supposed to be present the resident flora, essentially, that were constantly present on the surfaces of the body. They can't be a reason of HAIs, but everything is changing. This really is depending on the individual specifics and also from the society that we are in it right now. I would like to present to you the health facility that I work at for 3 years. I really like it. This is a small health facility. I think 100 beds, an inpatient department and 5 outpatient departments, and also 2 in Kyiv. This is in Tosana. This is a known emergency care hospital that has been created for more than 22 years ago in Odessa. And this was the best clinic of the emergency care in Odessa that were treating almost any patient. If any complex things is something impossible, then it's in Tosana. So then was I present this facility with pride. And
Згадаємо, що таке
so let's
кумулятивна
mention what is the cumulative antibioticogram. It's a great instrument that are helping us to at least approximately to know where to start when the patient is coming in the complex condition, in the septic state, and whatnot. And it's important that the infectious diseases process that will take biological materials. So this is the order number 1513 is telling us. And this is without a doubt a needed thing because this is in the interest of the patient. And this is something that can protect us from the prosecutor's office. So those are the pathogens that we had throughout 3 years in our clinic, independently on the fact that really the infectious disease, infectious IPC activities are being taught, but still the pathogens are still there. They're not going away because this is the same colonization of the patient that the anesthesia had mentioned. So those research that, as far as I know, are really much needed. So E. coli has been the leading cause of many HAIs cases that has been registered in our clinic. To say that in a year, we have been able to treat more than 3,000 patients, and out of 43 deaths, 13 has been caused by pneumonia or hospital-acquired pneumonia. Those are high numbers. And here is the representation of the bacteriological testing for gram-positives and gram-negatives, the comparison that has been detected from different biological fluids or clinical samples. And what we can see that apart from the pneumonia pathogens, they are given the general and outside of the hospital, so hospital and extra hospital, so that from 2025, they are almost going hand in hand because even the patients that are coming in as if extra hospital, they are detecting the typical in-hospital pathogens. This is why I wanted to have your support so that we can, within the framework of all the country, maybe this is impossible or hard to do, but to have the register of such a patient, maybe we need to start to have, because they might be, there has been a case, for example, in our clinic, a patient 56 years of age coming into one of the leading health facilities in Kyiv with the cardiac pathology after the replacement of 2 vessels. There was stenting or shunting, don't remember what was there, but he's coming into our clinic 3 days after he was discharged. He'd been there for 2 weeks. He comes into our clinic, and in the entry to the clinic, we find out TB, tuberculosis. It's coming with just the cough, with the high fever, and the cardiologist, cardiosurgeon, when he started to cough there more, but he was coughing before, but of course the surgery probably decreased the status of general health, and then it was a long form of tuberculosis. He was intubated, and he was there for 2 weeks in the inpatient. He was said that the cough will pass, so just drink something from the cup. And then when he came to us, then We took the gene expert, the sputum for the PCR, we sent the CT into the Center for the Significant Diseases. We isolated him in the isolation ward, but he came with the coronary syndrome. And so he'd been treated, and then but the problem is for 2 weeks, a person with very high level infection has been an inpatient, and he was just told that your cough will pass, you can go home. So this is the structure of the pathogens. E. coli, its overall number for 2 years, Klebsiella pneumonia, Pseudomonas aeruginosa. So most of the cases were caused by those gram-negative pathogens. So this is the dynamic of sensitivity. I will go in shortly, but what's important is that red line, this even the green bar, it's in the last 10 months. So the end of October of 2025, the susceptibility of detected flora or colonies or isolates. So what we can say is that the susceptibility is changing because the isolates that we are finding on in patients, they're different. And of course that because of the surfaces are being processed well, they're not staying there. So this is new isolates. But I would just like to mention that the circulation in the population, among the population of those pathogens that are coming from health facility to health facility, or because of the self-treatment, or those reasons have been mentioned by the previous presenters. But this is the general trend in the population. By having a good level of prevention of infections in terms of the hand hygiene, in terms of the processing of the surfaces, which is a key thing. And so we can say that the contact means of protection, or PPEs, for example, I listened to Maria, then we do have things to learn. Maybe this can be moving from patient to patient, but in the wards we have screening, so the ultraviolet lamp that are working constantly, which is the processing of the surfaces, which is a good foundation essentially. And so what I wanted to mention, that there are medication that are group of access, but to them there's no longer anything sensitive. But with time, everything is changing. So this dynamics, this has to be always under control. So the pathogens that are being detected, you have to monitor them all the time, their susceptibility. So for E. coli, Klebsiella pneumonia, here the situation is really bad because the susceptibility is only to tigecycline, and only just slightly more than 42 to 43% of isolates. For example, to amikacin, it's growing to 50%, and to the meropenams. So ciprofloxacin gives us a bit wiggle room. So the Pseudomonas aeruginosa, it's a completely different story. This is the big problem. Just cefoperazone is staying in the isolates that we have detected in our patient. So SRLs, the susceptibility is kind of high. It's good. And in the dynamic as well, you can see that in many medication. Enterococcus fecalis, here we can say that there's a form interhospital strain, so there is a circulating resistant pathogens. So what we mean is that this pathogen also have the right for the attention from the epidemiologist. So intra-hospital infections, or HAIs, it's a big issue because of the hospital pneumonia, a higher level, even in the countries with high level of development of the health system, we have the high level of incidence. And here's the etiological structure of the extra-hospital pneumonia in our clinic in the past 3 years in general. Streptococcus viridans most likely has been detected, Streptococcus pneumonia, Staphylococcus aureus, Pyogenes, epidermidis, and hemolyticus as well. We finally had the Staphylococcus hemolyticus. And so the susceptibility of Streptococcus viridans and this is regular outside of hospital with great susceptibility. Streptococcus pneumoniae, as we can see, the susceptibility is bigger part to the group of medication of observation, or watch group of medication.
The overall susceptibility, some general data for gram positives, just to see the trends. Etiological structure of hospital pathogens, hospital pneumonia, Klebsiella pneumonia was responsible for that in 40% of cases, E. coli 26, Pseudomonas aeruginosa every, you see, 10%. The hospital pneumonia, hospital-acquired pneumonia, dynamics of susceptibility. You see, everything less than 40% can be called resistant. So what is the algorithm to our mind of assigning, of prescribing empiric antimicrobial therapy in healthcare facilities, especially those providing urgent care? Microscopy of the biological sample sediment. So microscopy, in other words, you can do it quickly, and you can pretty quickly see what you see in the sediment. Is it gram-positive or gram-negative? Is it fungal? Is it anything else? Collection of biological material should be done in 2 vials. One for microscopy, so that bacteriology lab, even if it is not equipped with automated devices, at least would be able to understand after microscopy what they need to culture it, first of all. And a quick feedback, of course, of a lab technician to the managing physician, telling them what they see under the microscope. Prescription of empiric therapy based on cumulative antibiogram for the recent year or the recent 2 years. Even if you don't see many pathogens, you still need to be very careful with the development of this antibiogram. The sputum results, test results, this is what the lab technician can see under the microscope. So we can see gram-positive cocci, gram-positive rods. And an example of such a cumulative antibiogram for empiric therapy selection for the next year, 2026, based on the 10 months data collection from 2025. And you see, for empiric therapy, amikacin, dihecycline, and for gram-positives, you have a wider cefuroxime, cefotaxime, wider choice, ceftriaxone, vancomycin, amoxiclav, 89% of susceptible isolates. And we have Valentina Yanovska present here. And Valentina, deep words of gratitude for your enthusiasm and really creative approaches, and a huge work done to work upon combinations of antibiotics for pathogens that could be susceptible to those in Ukrainian realities. Of course, you can use some foreign literature to that, but these pathogens may differ, and their mechanism of adaptation and evolution may differ as well. And they can demonstrate susceptibility to different combinations. And one of the sputum test results, a patient with Klebsiella pneumonia, you see only susceptible to dihecycline and a bit of ceftazidime and a bit to another drug. I hope you can see. So we can prescribe amikacin plus dihecycline in this case, if the comorbidity of the patient allows that. And Some conclusions. It is very important to develop the protocols for empiric antimicrobial therapy, for community-acquired origin pathogens and hospital-acquired pathogens. And with that, probably, colleagues, I have to thank you for your participation, and thank you very much for listening. Thank you very much for sharing your experience. Thank you very much for this presentation. Colleagues, I have to say we're just a bit beyond our agenda, but the organizational committee allowed us to use just a bit of our lunch break, and we still have a bit of time to ask one question to each speaker. Please, ask your questions according to the topic. And the first who spoke was Ignat. Please, questions to Mr. Ignat Gavrilov. Hello, RCDC from Kyiv. My question is, do you plan to develop a map of antibiotic resistance for different regions among wounded patients? That is sometimes very important because the patient is admitted to a hospital, you have your sample collected, but then when the lab result comes back, sometimes it is not the best way to pass it by means of telephone messages or telephone call. It would be nice to use something similar to a WHONET system so that the information could be encoded and you would only get access to those whom you need. And do you also want to develop a protocol for the follow-up of wounded patients? Because probably we need to have a national protocol for that, I guess. I mean, I guess that means the follow-up treatment, probably.
Чудово. Дуже дякую за запитання.
Thank you very much for this question. I will try to make it very laconic. Speaking of your first part of the question, the colleagues mentioned that during the previous sessions and during yesterday, implementation of electronic tools, e-health system. This is what has already been started. And the NHS of Ukraine is the one that has a lot of plans. They are responsible for this e-health system, and we keep discussing with them multiple points and items to be included. Epidemiological surveillance system is also in the process of development. That is a lengthy process, but that will also include many items which were raised for discussion. So these issues, they are now in progress. What could be done today and right now, so to say? It is very important to have communication with the facilities at different stages of evacuation, at least informal communication, because that is done for the sake of your patients. Of course, that is a decision that requires some comprehensive approaches and comprehensive preparation, because it's about personal information protection, and we're talking about military people. Don't forget about that. We can't say it will be quickly done, unfortunately. Speaking of national protocols for the treatment of wounded patients, the problem is that we're talking about treatment of poly-resistant, multi-drug resistant cases. And these are usually severe cases. And we mostly talk about them in the context of purulent inflammation cases. And a lot of attention is focused on washing, on wound debridement, and then antibiotic therapy. It's about information from the previous stages of evacuation. So recommending some kind of empirical therapy is almost next to impossible in such a case. We're going to have colleagues speaking from Norway, and I don't know if they will speak about that or not, but what are the cases? What are the new cases? I'm not saying you just take it and use it, but in Norway, they use empiric treatment combination: ceftazidime, avibactam, aztreonam. So just do the calculations. there is a high probability they will cover all the bacteria they want, but it is not easy to, you know, to guess, to forecast that. So you need to focus on timely testing, timely screening, timely laboratory results, and then timely treatment. Thank you very much for this answer. A question to Anastasia, please.
Дуже дякую. Олена Машинець, Інститут молекулярної
Olena Mashinets, Institute of Molecular Genetics and Biology. Thank you very much for your presentation. Two questions about the design and results. Design. Did you look into, how do they call it, the lengths of stay of your patients in the hospitals? Do you know the median figure, at least? How long did they stay in the hospital before you actually conducted such a screening? And number two, did you plan at least to have it in parallel with the pharynx or from the upper part of the respiratory tract? Because we see from our cases, when there is a colonization with Klebsiella in the throat, sometimes it is a reservoir for further infection, but we don't see it in the intestine. Maybe, let me call it entrance and exit. Maybe we need to keep an eye on both. Let me start from the second question. The protocol, as of now, the protocol for surveillance has been confirmed by the ethics committee. It's going to be only the rectal swabs used as of now. Maybe in the future we will amend it or change it, but not yet. Speaking of your first part of question, the data that I demonstrated, these are the very first preliminary results. The data collection system, I mean demographic data, and how you called it, the length of stay. You mentioned the length of stay. How many days the patient stayed in the department before the screening. It was not included. But in the future we will think about that. And this information will be available in the IPC department. And these are the only people who will like understand why they need it, right? Because at the national level, we see de-anonymized, anonymized data, and we actually, when the IPC department, when they want to use it for some purpose, they can also focus on that figure. They can see the first name, the second name, what kind of patient, what kind of pathogen, how long the patient stayed there. So that is a very important piece of information for IPC people, but that was not so important for us, I have to say. Okay, thank you. Thank you, Anastasia. I feel there are very many more questions to ask, but we're going to have some time during the coffee break to do that. We're just a bit pressed for time. The next question is to me, to the next speaker. Anyone would like to ask a question regarding the monitoring and contact precautions implementation? Please. Hello, everyone. Vinica, clinical pharmacist. We all care about mental health of our patients. Did they ask you about any labels on the doors? Did it negatively impact their outcomes? Oh. No, I mean, did they pay attention to that? Well, we don't have any study dedicated to that, but that is a very good question, I have to say, because that is about these behavioral nuances. Yes, the patients responded to that. The patient reacted to that. Sometimes when you attach the label to the door or you attach it to the bed of the patient, if we're talking about a large-sized room, for example, and they will have a question about that. And the solutions, I see two solutions to that. Number one, the format of these labels. Some would use some kind of a code, let it be triangles or circles or something else, depending on the type of the pathogen, or maybe some precautions that need to be taken, like airborne or droplet or something else. Or the other option, the other solution, is that there is a requirement that the label should contain some specific information, what is that risk about and what needs to be done by the healthcare professional before working with the patient. And a lot what helps a lot is communication of a physician to the patient, the nurse to the patient, when you start, especially when you start implementing these approaches, because that is a bit, unprecedented actually for the healthcare professionals. That is also a bit uncommon, of course, for the patients. And probably the most important thing here is that it is very uncommon for the healthcare professionals. And if you communicate about that properly, they take it, they perceive it. Of course, there will be some patients who are gonna perceive it like something like a stigma because of some background. Probably you will come across some additional challenges with such patients that you will probably have to look for some individual solutions. But if that is common for your hospital, you see it on other doors, you see it in other departments, and everyone, reacts well to that, that turns into a common situation. It's about the culture of using these labels, so to say, and then it will be perceived much easier by the patient. So it's not about the reaction from the patient, I would say, but that is about the proper approach to that on behalf of the healthcare professionals. Thank you. And probably the last question to Olena. Please, colleagues. Anyone, please use your chance to ask the question. Okay, if no more questions, let me, as a facilitator, use the privilege to ask one small question to you. Olena, in the beginning, you mentioned that there are very many factors impacting the development of resistance, and we understand that. But one of the most important is the rational use of antibiotics. And we have some clear-cut recommendations based on AWARE methodology. This is the third appendix of this 1315 order. So what do you think, based on what we see currently now in Ukraine, based on the surveillance data, and what we see from our surveillance data in our hospitals, do you think it is reasonable now to amend the order? Oh, thank you very much for this beautiful question. When I participated in some other meetings, I could hear how our colleagues agreed to my opinion that not everything could be applicable from this AWARE methodology to Ukrainian realities. Why? That is because of the pathogens circulating in Ukraine and because of their features. So we definitely have to revise it. We definitely have to revise it. At the local level, why we perform this local monitoring? We want to understand what is available at the local level, what is circulating at the level of our population. So doubtless that we have to amend it and we have to review it. You, guys, as the regulating body, you need to identify how often do you want to review it? What do you want to review? From AWARE, we see that half of drugs, they are not registered in Ukraine. They are not available in Ukraine. Why would you have it on the list? Why would you have that list even more overloaded with information? The physicians sometimes are even scared to open it and look up for some information because that's absolutely busy. Another point, doxycycline used to be the reserve group. Now it is on access group, but there is no susceptibility. What kind of access group we're talking about? There is a whole list of other drugs that need to be also revised, I would say. Speaking of community-acquired pneumonia, ceftriaxone works pretty well. Why can't you prescribe it if it is functional, if it is effective? We're not talking about nosocomial. We're not talking about military servicemen wounds. These are just common Streptococcus viridans, and this is community-acquired pneumonia. And you have a lot of ceftriaxone, including those provided by humanitarian assistance pathways. Why not? Why would you punish people for using cephalosporins of such a high level of generation? Well, I'm giving it as an example. But my idea, my opinion, is that yes, we have to review it, and yes, we have to adapt it to our Ukrainian realities. Anything to add? Thank you very much, Olena, for your answer. Let me join this discussion. The AWARE classification suggested by the WHO sets the principal distribution of antimicrobial drugs depending on their potential to develop antimicrobial resistance. And to a certain point, it is about the priority of their use, I would say. There is a certain correlation between how quickly the resistance develops. In the access group, it is lower. In the watch group, it is different. And the access group is recommended as a first line, but this is not always like that. Sometimes, for some conditions, the watch group could also be used. The reserve group drugs need to be properly justified. It does not mean you cannot use it, but that means you need to weigh your decision. You need to use bacteriology lab results, and you should say, like, yes, that was the reason. But there are always exclusions. There are always, situations to that with lots of nuances. We keep talking, like, the medicine is a very complicated field with lots of different, things and tricks. And as we already started talking about this AWARE classification, as Ihor Kuzin mentioned at the beginning of the Congress, he said, as of today, the operational plan for IMS plans to review the standard 1315, and they plan to include some important points to that. It's not because it was skipped before, but they're gonna introduce the fourth group, because the AWARE original classification used to have 4 groups. The fourth group is non-recommended combinations. And cefotarizone sulbactam. In this combination, it is not recommended by the WHO. You can do it separately, but you should not use it as a combination. So they suggest to include this group and to improve it. The 1614 order from the Ministry of Health is also under development right now, but there are some confusions because in the 1314 there was a template SOP dedicated to AMS stewardship, and they wanted to demonstrate that depending on the local situation, the healthcare facility could define what they can use, like doxycycline on the reserve group. This is what Elena talked about. That, I have to say, came there by chance, so to say, unexpectedly to the group, reserve group. So this our classification should be used as it is used in the 1315 order. Doxycycline is the access group drug. But please, don't forget what this classification is about. It does not mean that you must use only the access group. You should not be afraid of the reserve group, but this is about your priority. This is about your meticulous approach to prescribing different groups of antibiotic. Thank you. Well, thank you very much, Ignat. I have the feeling that the discussion will continue, will definitely continue once we're done here. Please come back at 14:15, at 2:15. Thank you very much, everyone.
see via laptop.
Better, right?
Yeah, looks fine.
Is
Looks
this
great.
better?
Great.
Yeah,
Yes.
yeah, yeah. That's better. So
Can you
should
try
we
to
try
share
to
the
see?
presentation?
Yeah, share the presentation.
Yeah, you got all permission. You can try.
Okay. So share. So I can put it like in a slide mode. Okay. Can you see this?
Yes, looks fine. It's full screen. In full screen.
Yes. Good. Okay, so then we just do this. Now I stop sharing, right?
Yes.
Okay.
Okay, everything looks fine. Everything is working.
Okay, perfect. Thank you.
I believe we will start in 2-3 minutes.
Okay. Okay, you're right on time. Good.
Yes, great.
If not, and then we just stay on, right, for the Q&A session.
Колеги, займаємо ваші місця. Ми будемо
Colleagues,
продовжувати.
please resume your seats. We have to continue. Colleagues, taking photo right now. You're gonna have a chance to do that after the Congress. Don't worry.
Марія Панасюк, вам лише як на правах модератора.
Maria Panasiuk can take another photo. Well, she used to be a facilitator just now.
Ну що ж, чудово, всі займаємо ваші місця.
Okay. Colleagues, please resume your seats. Don't forget to close the door to keep the noise out. Thank you.
Ось ми і, на жаль, завершуємо наш
Okay.
конгрес.
Colleagues, we're now coming to the final, unfortunately, final block of our today's Congress. But this is not actually the final step, because after that, we're going to have another thing. You remember I talked about this roundtable discussion. Before we actually get down to the block number 6, let me ask our technical colleagues to demonstrate the keyword for the second day. That one is going to be used for continuous professional development purposes. And this word is aseptics. And that is only for those who are really the fans of hand hygiene and for the IPC practices. Okay, block number 6. This is where we're gonna speak about bacteriological diagnostics in the field of antimicrobial resistance, and the facilitator to this block is gonna be Valentina Yanovska, consultant for bacteriology testing of the Ukrainian Public Health Center. Everybody knows Valentina perfectly well, and we also know about her input into the system of laboratory diagnostics in Ukraine. So, Valentina, over to you. Hello, everyone. Thank you very much, Ignat. Colleagues, welcome to the last session. And the bacteriology session is like a cherry on top of a cake. Bacteriology has been talked about very actively for these 2 days. And finally, now we're going to have a chance to listen to people working in these laboratories. And the first person to speak during this session is going to be Torun Newgard, a physician from from IPC department, Ullevål Hospital, Norway. Can you hear me well? If you are ready, please take the floor.
Hi, can you guys hear us? Yes?
Yes, we can hear you. Elena, we can hear you.
Yes, perfect. So now we start the presentation. Sorry. Torun? Oh, okay. It's a duo. So, and I'm here on behalf of Miriam Sare, who many of you know, but unfortunately, due to illness, she had to be away. So we're going to talk about the war-injured patients and the IPC experiences from Norway. So on this slide, the figure shows our AMR surveillance data at the Norwegian Institute of Public Health. These are monthly reported cases of carbapenemase-producing organisms. And as you can see, we saw a sudden increase in cases in June of 2022, which corresponded with the start of the Ukrainian Medivac patients to Norway. And Medivac is the cooperation between European hospitals and Ukrainian hospitals, which allow to bring the patients from Ukraine injured by war. So we realized quickly that there was something unusual happening and started looking further into details. Can you guys, I hope you can see the slides well, yeah?
Yeah, we can see the carbapinamase producing bacteria in Norway slide.
Perfect. Okay. And so this figure shows the carbapinamase producing organism cases in Norway per year by assumed place of infection. In the dark red portion of the bars, you can see cases that are reported to be infected in Ukraine before coming to Norway. And in 2022 and 23, it was a significant part of the annual cases, about 1/3 of all cases in 2023. I hope you can see them. And decreasing the last 2 years, but Ukraine is still the single largest foreign source of reported CPOs in Norway. So the slide here is borrowed from our colleagues at the Department of Microbiology at Oslo University Hospital, and it shows the microbiological data on the first 45 war-injured Ukrainian soldiers treated at Oslo University Hospital. They were all screened upon admission to the hospital, and all except 3 patients were positive for at least one multi-drug resistant bacteria. All patients were isolated upon admission while waiting for screening results. Out of the patients that tested positive for screening, most patients tested positive for CPO. Many patients had more than one CPO at the same time. There were also some patients that tested positive for MRSA, vancomycin-resistant Enterococcus, and Candida auris. Since the IPC department at the hospital received data from the microbiology department early, they quickly started developing IPC procedures specifically for this patient group. So our colleague, Toren Nygaard, which we're very happy to have here, IPC doctor and head of IPC at Ullevål Hospital, will further present how they have managed multi-drug resistant organisms in war-injured patients.
Thank you. And then I will continue about our ward in Oslo. My agenda, the Medvac unit at Oslo University Hospital, Ullevål, the IPC at the Medvac unit, interdisciplinary collaboration, and our challenges. So then first, the Medvac history at the Oslo University Hospital. The first Medvac patients arrived in the summer of 2022. These patients arrived at different units within the hospital. Our experiences were need for high competence within multiple discipline and coordination and collaboration between these. And the patients were colonized and infected with extremely resistant microbes that the hospital had no former experience with. There were high need of communication between the involved professionals. So then, Medvac patient from Ukraine to the orthopedic unit. In autumn 2022, it was decided the need for a dedicated Medvac unit. And in the end of November and December 2022, we prepared for the unit and it opened in January 2023. The unit had 6 beds. The total amount of patients since start have been more than 64 patients, and average admissions days are 60 to 90 days. Most patients have readmissions, and between the admissions, many of them have been to rehabilitation in another unit outside the hospital. Type of treatment to the patients are injured from blasts, spleens, surgical site infection, osteomyelitis, and yeah. Some have other underlying diseases as hepatitis B, C, TB, etc. One patient had lung tuberculosis. The IPC at the MedVac unit training of staff. We had a collaboration between microbiologists and IPC staff to prepare and do the training of the team. The microbiologist explained what was different about these patients, because that was not known for the team working with the patients. And screening routine, which tests and how to take them. The IPC staff adjusted training for all discipline, all on the list you will see later, and plus radiologists. And we helped to improve routines in the ward. Here you see the screening procedure for patients from Ukraine. The colors is just to differentiate between the microbes. We test for MRSA, or methicillin-resistant Staphylococcus aureus, ESBL, extended spectrum beta-lactamase, also then CPO, vancomycin-resistant and linezolid-resistant Enterococcus, Acinetobacter baumannii, Candida auris, and tuberculosis. But just one tuberculosis in the lungs. And here is the procedure for patients from Ukraine. This we have in our intranet, open for everybody, in a handbook, where we have all the hospital's procedures. And now this procedure is changed to be for everybody transmitted from hospital abroad. It's not only from Ukraine, but all hospitals outside Scandinavia. And then about our focus areas in the training. Donning and doffing ensure that everybody performed correctly. And observation of colleagues. The colleagues observe each other every day to make sure that they take off the equipment correctly, not to contaminate the area. Tableware from the patient room via the contaminator to the kitchen. Reusable equipment from patient room via the contaminator to the clean room. We made small interior renovations that made it likely that the employees acted correctly. Especially we did that in the room with the decontaminator and in the ward's kitchen. Dedicated staff from the Department of Infection Control were available by phone and for presence when needed, weekdays from 8 o'clock to 4 o'clock. And the IPC staff also assisted at visits from media, politicians, and etc. And the interdisciplinary team was very big. It was orthopedic surgeons and the theater team, nurses and staff nurse from the ward, physiotherapist, psychiatrist, clinical nutritionist, microbiologist, infectious disease specialist, cleaning staff, and IPC doctor and nurse. And the interdisciplinary collaboration, we had common approach and understanding, continuous dialogue, answer questions in plenary. The whole team involved in IPC. We had weekly interdisciplinary meetings. All the discipline updated each other on status of treatment and the plan for the patient. Needs for IPC precautions were shared with the whole team. Dedicated time for questions and the documentation. We found practical solutions for physical mobilization, social needs, to get outside in the sun and in fresh air. and at the same time maintain IPC recommendations. And then we also had some challenges. The aim was to prevent spread of multidrug-resistant organism from medevac to other units in the hospital. Since the start of medevac unit in January 2023, there has not been detected spread of multidrug-resistant organism from medevac to other units in the hospital. And also there has not been spread between the patients in the medevac unit. One big challenge was understanding the need for IPC precautions among medevac patients. Even the nurses explained, it was very difficult to understand, and they came from hospitals where this was not implemented. And they were isolated for a long time, and then at the same time not understand was an extra challenge. Visitors and adherence to the guidelines was also not always easy. Different IPC approaches within different institutions, also in Norway, and from where they came from and to us. And no restrictions outside the hospitals. Language and the need to communicate via a translator was a big barrier. Even with adjustments, the IPC precautions limit the patient significantly, so that make it more heavy to be in their condition. So thank you.
Thank you. I guess we have questions and answers later, right? But this is it from us. Thank you.
Так, я попрошу вас
Yes, so
залишатися.
can we ask you to stay, because the Q&A session will be after the finishing of all the 3 parts of the lectures and then this session. Thank you so much. And then I'll kindly ask for our colleagues, Olena Mashinevich, Cabinet of Medical Sciences, Senior Scientific Employee of Institute for Molecular Genetics, which is one of the few of our scientists that are dealing with the issues of resistance in Ukraine.
У нас немає до часу, да? Тож, Валентина, будь ласка, якщо я буду... будь ласка. Шановні колеги, мене сьогодні
Dear colleagues, I was presented before by Mikola, and then we are working with Zimaitin, but the lecture is not going to be about that. It's going to be about our attempt to understanding how war had influenced the tools and the molecular genetic aspect of the resistance in Ukraine, because the phenotype is more or less can understand, but what is happening with that phenotype we were trying to find out. And right now I'd just like to present to you the result, which is the beginning of the project, which is a joint research of the group of Ukraine within the European project for the development of the scientific sites in the Molecular Genetics and Biology Institute. We are working with the German colleagues as the Bonn Clinic and then with the research center in Poland, and also with our colleagues in the Britain. They have the diverse group. So this is the joint results. Some of them were received by us, some of them by our colleagues, but we were trying to systematize them so that we would try to understand and to see the whole picture and the overall trends to be there. And at first, I'd just like to motivate you to help us with the understanding, like, how are you professional specialists, the personnel in the MAMR are treating the antimicrobial resistance? How are you positioning yourself? How are you perceiving all of that? So this QR code I will give you in the end of the lecture, and we will be really grateful for your answer. This will help us in our project. Then let me start from what you know. The issue of resistance, this is the general threat to the world, but I would just like to highlight, we don't know what is the forecast, so that we imagining that there is a forecast, but those forecasts are changing from year to year. We are seeing that there's different level of mortalities being forecasted. In the last forecast as well, it's 39 million deaths up to 2050. This is the direct mortality that is directly connected with the, indirectly connected with the AMR, also risks are not taking into account. The risks are big. So we all know and we all agree that the problem is critical. And it's not just medical, it's social, economic, it's about the humanity altogether. And unfortunately, this is an opportunity for all of us to start cooperating more in Ukraine and also improve our international cooperation, because there's many epidemiological and molecular testing is done without Ukraine. And so here I'm just making a summary of the few of them. For instance, in KPC producing Klebsiella, Ukraine is absent. That Ukraine has a big epidemiological meaning. So OST 161, Ukraine is not there. To 2023, instead of the war, still Ukraine is not there, because unfortunately Ukraine is influencing the global resistome. And so we see this from the scientific publication in separate cases. This is just the tip of the iceberg. And we understand that the issue is much bigger in scale, and epidemiological influence of the Ukrainian isolates to Europe is much bigger, even though the publications are growing in numbers about the ecological and epidemiological MDM1, NDM, and OXA48 in Germany. Our Polish colleagues studied the Ukrainian isolates, the influence on their national resistome, and so the research that highlight the MDM producing Klebsiella at first in the Netherlands and the Spain because of the patients in Ukraine. So that we are just destroyed epidemiological safety in Europe, and so because of that, this issue is outside of just Ukraine, and maybe the competencies of Ukrainian Haley Warren, that had a wonderful motivating lecture yesterday. This year she published a revolutionary article. This was the global antibioticogram that was conducted for more than 6,000 isolates from the patient of the first territorial medical union in Lviv, because we saw the scale of issue and we noted it down. So what do we have to see here? So here at this, the numbers are really small, but the main principle is that was mentioned before. The gram-positive strains are more or less susceptible to linezolid, vancomycin, and this is around 50% on antibioticogram, and 50% of other strain, which is gram-negative, and they are much more resistant to meropenem, imiropenem, tazobactam, ceftazidime, and also sometimes it's 12 to 10% of susceptibility. This is very low levels. As it was mentioned today with carbapenems, I guess the best antibiotics that the humanity did, because they are really great. They are bioaccessible, well tolerated, because therefore the loss of carbapenems is the big loss for the treatment of the patient. Therefore, carbapenemase is one, carbapenem resistance is one of the bigger issues that we're having. And so how did it happen? Why the gram-negative ones are dominating into the as part of the issues that we have? And so nothing new here. We know the answers. This is the evolutionary drive, and by getting outside the biotechnology, we know the gram-positive bacteria lost this war, but gram-negative has won, because therefore the cell wall is much more effective against the biotechnology such as antibiotics. So what are we speaking? The gram-negative cell wall has two membranes, and among them there's transmembrane space, periplasm, and it was concentrating the hydrolysis of lactam circle and carbapenems and cephalosporins. So we're speaking that this concentration of those enzymes, and this is in enzymes. So we are only speaking about carbapenems. The other issue, which is not different types of resistance, which is for the carbapenem resistant from meropenem, imipenem. We're not speaking about the imipenem, doripenem. So this non-enzyme tool has to be included, not with just carbapenemase. Carbapenemase is additional tool, but the main one is the presence of the increased expression of FLUXA. And so FLUXA is of importance as well. So in combination of those non-enzyme and enzyme mechanism gives us the phenotype of resistance to carbapenems. And so the resistance and issue of resistance became there not because of the war, not yesterday. And so we decided to study this trend. The scientists from other groups of research, they looked at how does the sensitivity change from the antibiotic medication in Kyiv State Hospital And you can see up to 2022, we still had the sensitivity has been decreased slightly. And with the full-scale invasion, the trend didn't change. And so by the example of this hospital, we were trying to understand what did happen in terms of tools. So we were trying to study on the collection of culture that stayed with the full genome sequencing, trying to understand like what is the genotype of that we are observing. But what are we speaking about the genotype? We separated Enterobacteriaceae and Acinetobacter as well. So on the phenotype, to antibiotics that are still staying after the fixation of carbapenem resistance. This is colistin, and so you can see that Pseudomonas aeruginosa is changing a bit. It's still staying the small sensitivity to Cephibus. This is Avibactam. So Acinetobacter is going slightly worse. We see the Cephididacal at the beginning of 2023, and we have 41% sensitivity only, and colistin is still staying there sensitivity. But this is how enterobacteria looks like, mostly Klebsiella. In 2022 to 2023, almost sensitivity doesn't change to colistin. It's interesting that the sensitivity to Cetirizine Avibactam is increasing. So Cephididacal, the so what are the genetic mechanisms that are connecting with that? So we were trying to understand this. And so we just did our first result of whole genome sequencing, and this is what we've seen. So there was an STX, and which is the cephalosporinase. But what can we see? The AXA48 is increasing, YKPC is decreasing, and what's important that there was an NGM to carbapenemase, and we also have the amount. So it's only getting to 36% of strains have this carbapenemase, and this is correlating with the recovery of sensitivity to Septicemia avibactam. Usually, this is newly epidemiological lines that has been included with the new patients with the hospital. So not that the strain has been lost to carbapenemase or something, but the new strains are came without the carbapenemase, therefore sensitivity has increased. But we will be looking forward to finding why this has happened. So this situation is on one local hospital in Kyiv, but we would also like to say what is happening in the country altogether. And so the first epidemiological research has been conducted by our colleagues from the Polish National Reference Centers. So 65 isolates of Klebsiella carbapenem resistance, they isolated from Ukrainian patients that has found the treatment site in Poland. And so this year they has published this line of research. And this is what our colleagues got was from the Klebsiella, carbapenem resistant Klebsiella that has been isolated in 2022 to 2023. EPC 24, OXA 48, and GM 61, slightly higher than V. And we even found one strain that's the and MDM and OXA, usually was OXA 48. This is what the German colleagues mentioned, the Polish colleagues as well. So this is more of the trend for Ukraine on the co-production of OXA 48 and MDM. So let's try to compare this general research. The patient has been from all the Ukraine, so this is more or less epidemiologically representative for the country with our local data on Kyiv Oblast City Hospital. So we had the KPC, the Polish had on all the cohort of Ukrainian strain, KPC has been, we did not have it, and 48 has been the same percentage. And DM, as we mentioned, it was lesser, and VN we didn't have. So there was some difference, but nothing has finished with that because the war is not over. The evolution is also not over. So the next stage, we would try to understand like what is happening with carbapenem resistant strains in 2024. And for that, we decided to reach out to a few of the labs. We also reached out to you, so thank you so much. This publication wasn't possible without your help and assistance. So we have received the strains from the Kyiv region, Kryvyi and Kharkiv. And we reached out to our colleagues with the request to give us carbapenem resistant strains. But as you can see that the strains have been slightly 13% of enterobacteria has been susceptible to carbapenems. Therefore, we removed them from the study. But the strains that have been confirmed phenotypically by our British colleagues, they resistant to carbapenems, what was there? So here you can see in blue color, which is the strains in 2023. So what was procured from Ukraine, the light gray, this is our research from the local Kyiv region. And then the dark gray, this is something that's governed by our Polish colleagues. So the tendency that everything is getting worse, the 66% sensitivity of the decrease in Cefidimobactams, Acinetobacter becoming less susceptible to colistin, cefiderocol, it decreases its effectiveness even though it's haven't even been used in Ukraine. Enterobacteriaceae, colistin, in 2024, our strains that has been randomly selected and carbapenem resistant, mostly Klebsiella, they have been resistant to in 400% of the case, in 400 cases. One of this, they had the MCR1 gene, the gene for the colistin resistance, the gene that could have came to all of our strains from agrarian environment. So all of the other resistance, so this is the de novo new new generation. So during the treatment in hospital, so those are the ones that just became resistant, isolated in the hospital. So regarding ceftazidime-avibactam, the sensitivity is going down. Cefiderocol is only 50% anymore. But the most interesting, what are the tools that we have for 2024? As you can see, for 3 cohort of gram-negative flora, we have co-production of carbapenemase. So the ones that are producing just one carbapenemase is not sufficient enough. But the main thing for us that there is a different cohort. There is a cohort of carbapenem resistant strains that don't have carbapenemases, especially for, we have a third of strains without carbapenemase, carbapenem resistant strains, which is clear for Acinetobacter, but never I seen this publication for Enterobacteriaceae. So we are speaking deripenem, and then we are speaking mostly about the full resistance to carbapenemase. So it wasn't described before, but unfortunately we found it. And so what is happening in 2024, almost 30% of the KPC, we have 36% of OXA, 56%, so almost the same numbers of NDM. And we are having a cohort, not carbapenemase, producing Enterobacteriaceae, so there's 3 Klebsiella and 1 Escherichia coli. So if you compare with the research on the 2022 to 2023 of our Polish colleagues, as you can see, we have the growth in KPC, we have the growth in OXA, we have almost no change in APM. And our Polish colleagues in 2022 to 2023 didn't find it, didn't publish any Klebsiella gram-negative bacteria that would not have carbapenemase. So we retrospectively are conducting sequencing and research on the strains from 2022 to 2020, and we haven't yet found on the Kyiv City Hospital, we haven't found any antibacterial strain that would not have carbapenemase. So this is something new, a new trend. And so if I have the time, or do I not have the time? Okay, I do have the time. I'm not gonna read out for the conclusions. I would just like to point your attention, dear colleagues, we do have an issue with the development of resistance, or tools of the resistance. I would just like to point your attention to the issue of the phenotype. Phenotype is not always being described by the genotype. Genotype not always describing the phenotype. Genotype is for the local national epidemiology. Phenotype is for the patient. Therefore, the phenotypes are not changing. This doesn't mean that the genetics are not changing. We see on code that we don't have, but the resistance is growing. This is a change in tools. And so we have to study this, forecast this, and so that to correct our policy somehow to combat this. And most likely, I'll finish my presentation with that. Thank you so much for your attention. Thank you so much, Olena. And this was our science. And now I'm passing the floor to the practical portion. And so I'm welcoming Yulia Alimenko, who is a bacteriologist, microbiology lab of the Zaporizhia Center for Disease Control and Prevention. So I'll be brief and quick. I just wanted to reach out to you, and so on such an issue that there's an increase in spread of Marginella family connected with the wider usage of colistin. As of today, the key threat is the spread of multi-resistant form of flora, especially gram-negative bacteria. This is discussed a few times today. Colistin is one of the few antibiotics that are still having activity against those pathogens, but its wider usage is also taking some risks, such as a selective pressure that increases the growth of the bacteria that would be resistant naturally to colistin. So the Merkinelata is the bacteria that is resistant to colistin by nature. The objective of our research was to assess the growth and the spread of bacteria of this family among the patient with the septic conditions that has been treated in the inpatient conditions in Zaporizhia. So we've covered a period from 2022 to 2024. So we had, in the framework of our work, so we have used retrospective analysis, so more than 10,000 results of microbiology testing of patients with different localization of those septic conditions. So the lab materials or samples have been from different localizations. So we reached out to, and we decided to understand what is the sizing of the bacteria of Proteus, Serratia, and Protea. And so the statistics data processing has been done with using the back lab data set that is used as the laboratory information system. So what have we detected? That during the 3 years, we having a specific list of growth of the added value of the Marginella bacteria. If in 2022, this was only 5%, and in 2023 it was 9%, in 2024 this was 12%. And so now on the previous discussion, this is 17%, in some of the department it goes to 20%. The biggest increase, the Protea mirabilis, vulgaris, and Morganella morgania. So we are also seeing new representatives, such as that we haven't seen before, or rarely seen before, Serratia marsensens and Serratia ribidea, and others. In 2024, the Protea mirabilis made 7% among all of the isolates, which is twofold more than in 2022. Overall, we were mostly mentioning that the increase in beg your pardon. The received result allows us to achieve that the growth in this percentage of Marginellata is connected directly with selective pressure connected with the usage of colistin. The bacteria that have inborn the polymyxin has the selective advantage. Overall, our results of the research are showing that you need to review the approaches to the treatment to not to cause the selection of microorganisms that will not be susceptible to polymyxin. I would just like to point your attention that if we, in the beginning, probably seen Protea only in urine in cystitis, and right now we are seeing that in Providencia and almost in all of the wounds together with our regular bacteria, like Acinetobacter baumannii, Klebsiella pneumonia. So they are there. If beforehand they had the regular antibiotic sensitivity, and so the microflora has been okay, then right now they are becoming more aggressive. So more and more and more their resistance to bigger groups of antibiotics. This is why I am worried, so that we would not get to our escape group another letter like P or Protea or M Marganella. This is why I'm like for you to have more detailed approach to the prescription of colistin. So much stronger criteria of prescription to review the protocols for treatment, and our recommendations is to conduct the monitoring and control in hospitals and on the department to make dynamic maps to just see how frequently your department you're having the bacteria Marginariata from that family, and to add into the local protocols the departments on the treatment of protests and other parts that can be a part of AWARE in the future. Thank you so much.
Дуже вам дякую. Дуже
Thank you so much. It was an interesting and practical information for our bacteriology labs and the departments of infectious control and the hospital. What do they need to point their attention to? So then on by the plan, as far as I can see, Miriam said I will not be able to join us, right?
No, she's joining. She's joining.
Дуже чудово.
Oh, that's great. That's great. Then the next presenter, which is the Miriam Sarey, the expert on the medical microbiology, senior physician of the Department of the IPC and Emergency Response in the Norwegian Institute for Public Health. So please, Miriam, the floor is yours. Thank you so much.
Hello, nice to see you. Nice to be with you on Antibiotic Awareness Week. Let me share my presentation. Yes, you can see my screen. Wait, let me go to the first slide. Yeah.
Так, бачимо.
Yep. Okay. Yep. Thank you. So I will give a brief presentation on an antimicrobial stewardship tool that we use in Norway that we call selective susceptibility reporting. So we wanted to use the most common communication channel between the microbiologist and the clinicians and the IPC department to do antimicrobial stewardship, and that is the lab requisition. So this is a lab requisition in Norwegian, which says that the patient has a urinary tract infection and receiving antibiotics, and that the clinician wants a culture. And this is the communication back to the clinician. So the microbiology lab found an E. coli from the urine, and this is the antibiogram that is showing. And here you can see there is susceptibility to all the antimicrobials, and all of these antimicrobials are quite narrow spectrum, so it doesn't really matter from an AMS standpoint which antimicrobial you use. But what happens when there are very many antibiotic options? Here you can see also a urinary sample with an E. coli, and you can see a different kind of antibiogram with a lot of options, and all of these are also sensitive. So here the doctor could choose to use an antimicrobial that is recommended by the guidelines, or they could choose something that they are familiar with, or something that is cheap, or maybe something that has small pills that are easier to swallow, or something that is available close to them. So there are many factors that influences the decisions on what antimicrobials you use. We know from studies that prescribing is influenced by what is being reported and how it's being reported. And the literature suggests that selective reporting of antibiotics can reduce unnecessary use of antibiotics in both hospitals and primary care. So based on that, in Norway, we decided to try to use selective antibiograms, which is a way of reporting to the clinicians the antimicrobials that we consider necessary and not others. And what is considered necessary is determined from the clinical information and from the microbiological results. The goal for us with selective antibiograms was to avoid that the report from the lab stimulates to unnecessary prescribing of antibiotics and to help the clinician choose the preferred drug. Another goal, because we implemented this in the whole of Norway, so another goal for us was to standardize and assure quality in the test and report practices in Norway. So in 2017, we held a consensus meeting. I was part of the committee who organized this meeting. And it was a meeting among microbiologists from all over the country and clinicians as well. And the aim of the consensus meeting was to decide how we could make these selective antibiograms. And there was agreement during the meeting that 95% of participants agreed that unnecessary reporting of broad spectrum antibiotics should be avoided. So from that, we started a working group. I was also part of that working group, and we worked for a couple of years on how to implement this and do this in Norway. And we came up with this algorithm. So in the lab, when there is a positive culture, we ask the question, is it likely that the bacteria found is the cause of the infection and needs antibiotic treatment? And if the answer to that is no, then we discontinue. We don't do an antibiogram at all. If the question to that is, I'm not sure, then we do an antibiogram and we report what we call a zero panel. So that means that we do the antibiogram, but we don't report it. We just keep it at the lab so that if new information is coming to the lab, that this is actually something that is important, then we can give it directly to the clinician, but otherwise they won't see it because we don't think that they should treat the patient for that specific bacteria. If the answer to the question is yes, then we ask a further question. Is it sensitive to 2 or more antibiotic classes in panel 1? And panel 1 is the first line treatment, and it's in accordance with the national guidelines. And if the answer to that question is yes, then we report panel 1. If the answer to that question is no, then we ask, is it sensitive to 2 or more antibiotic classes in panel 2? And if the question to that is yes, then we report panel 2, which is first line treatment, but also with extra antibiotic classes. And if the answer to that question is no, then we report the reserve panel, which is basically everything that we have tested for. So this is what it looks like in practice. So this is for an example from our algorithm for a urine sample with Enterobacterales. And you see here that the green ones, M1, that is the first panel, that is what we always report. If we have resistance to some of those antimicrobials, we report M2. And if we have resistance to that, or can also be allergies or other circumstances, we report M3. So this is for primary care or for an outpatient. And then for inpatients, these lists will be a lot longer and contain more antibiotics and more IV options. So some of the challenges with using selective antibiograms is agreeing on the antibiotics in the panels. It took a lot of time and a lot of work, but eventually we agreed on the different panels. And now it is, I think when I talk to clinicians and microbiologists, I think that everybody feels like they were involved in developing this and that they agree on the panels. The implementation can be a problem because all the labs have different lab systems and the different labs have different resources. It takes time to implement new things. But by now we have pretty good implementation, but it's been taking a few years to get everybody on board. And it's not necessary to implement it in the whole country. It's also possible to implement it in certain labs. And measuring the effect is always difficult with antimicrobial stewardship tools because you use a lot of tools at the same time and it's difficult to know what's working. But we, at least we know that our clinicians like this system, and they feel that it's a help for them in antimicrobial stewardship. So that was a brief introduction, and we are happy to share our experiences further if any of your labs are interested in this.
Дуже дякуємо, Мір'ям.
Thank you very much, Miriam. Please, if you can stay with us during the questions and answers session.
Наступним нашим доповідачем
And the next speaker is going to be Ludmila Ishchenko. She is a laboratory specialist working with ACOP.
Колеги, вітаю. Це вже остання доповідь.
Hello, colleagues. The last presentation on the last block, so I'm not going to take much of your time, so be patient just a bit. Let me quickly share with you some experiences with regards to cooperation among bacteriologists and clinicians in the field of improving the quality of hemocultures, of blood cultures. I think every second topic during the Congress was dedicated to cooperation between laboratory people and clinicians, not only to overcome the AMR problem, but also in many other topics. Why do I want to speak about blood cultures? I think we all realize that the blood culture is really a topical and a relevant topic for discussion always, because that is considered to be a golden standard for diagnostics of BSI and effective treatment of sepsis. But we also want to minimize the false negatives by means of getting the proper amount of sample per vial. And we want to have at least 2 sets of samples, which is actually a reasonable problem for Ukraine. Often the case we collect only 1 set, and that gives you 20 instead of 40 microliters. And that means that the quality of further diagnostics might be compromised. Another important factor is to avoid, as I mentioned, the false negative results via the potential contamination of samples during blood collection. This is especially important when you only have a chance to collect 1 set of samples, or when you do not get the proper volume. That is, again, a problem. And that is usually the failure from the pre-analytical stage. This is basically the problem, the failure of people who do the collection. If we talk about contamination, on the other hand, that might be the problem associated with the laboratory work. Let's say if 1 of 4 vials gives you growth, you can see that, well, that probably looks like there is a higher risk for potential contamination. But you can suspect it in the lab. And you can confirm it only by means of direct communication later with the clinicians when you discuss the patient symptoms. And the decrease in the contamination rate will very much depend on the clinical team a lot, because they are the ones who really need to implement the best practices for blood collection. The blood cultures contamination remains to be a serious problem, which brings me to the topic of my today's speech, and often the case that leads to unnecessary use of antibiotics and unnecessary high cost. And you see a publication here dated 2025, and there was another publication back in 2006. So we see that the problem persists. The proper quality of blood cultures requires close cooperation between the clinical team and the laboratory team. We also have to add some Ukrainian context to that. We usually, as a rule, have a low number of blood samples collected for bacteriological testing. Often the case we collect only 1 set, which is also a critical point for the diagnostic value of blood cultures. And one more thing that we currently lack in Ukraine is that we do not have a systemic monitoring for blood cultures contamination. we have already said that we're having some projects dedicated to quality improvement. And when we had a chance to, during our visits, to discuss with our laboratory colleagues what kind of contamination rate.
Всі казали, що він є, ми знаємо про цю проблему, але такого системного моніторингу ми не проводимо. В зв'язку з певними обставинами. Тому, власне, ми сфокусувалися на тому, щоб допомогти лабораторіям проводити такий системний облік або моніторинг рівня контамінації гемокультур. Але знову ж таки, як сьогодні вже говорила Марія Панасюк, що якщо впроваджувати щось нове, то дуже гарний підхід можна використовувати саме методологію покращення якості, тому що ця методологія, вона дає такий комплексний підхід до проблеми і до аналізу причин цієї проблеми, і, власне, до шляхів рішення, тобто ідей змін, які можна використати для вирішення тої чи іншої проблеми. І, власне, от ми також застосували такий міні-проект.
Sorry, probably there was a little problem with connection. So we decided to make use of this quality improvement and we decided to use the following methodology for that. So,
by understanding this problem,
the proper understanding that there is a systemic problem with that, with regards to the blood cultures, we decided to take a very comprehensive approach. And we decided to focus on three methodology approaches. Number one, we invited two microbiology specialists from European countries so that we could provide our colleagues with some methodology recommendation and support to our microbiologists as well as our clinicians and medical nurses on the proper approaches to blood samples collection so that they could know about the best practices in that field. Moreover, the European colleagues were involved into some laboratory testing activities. We talked about some basic approaches like gram staining. And I have to say there were some problematic issues identified there. And also, one of our European colleagues worked upon the topic dedicated to proper communication once you obtain the laboratory test results. We, as the ICAP team, taught the bacteriology people about some methodologies, how this quality improvement project could be implemented. And I have to say that the project is still ongoing, by the way, a brief spoiler to everyone. And the colleagues involved were supposed to develop their quality improvement projects and implement them in their respective sites. A brief timeline here, how it looked like. We started doing that project. Sorry, we need to indicate here 26. We started doing that in June. And the final session is going to be conducted in December to come up with some conclusions. It all started from June 2025 when our colleagues from European countries conducted a series of lectures about the best practices for blood samples collection. We focused not only on blood, but sorry, that's just the topic of my presentation about blood. We also focused a lot of attention on wound samples. So we noticed that there was a lot of interest from clinicians in these topics, and they could hear from our European colleagues how that actually works in their European facilities, in their European countries, and that brought to some positive effect. During the training in the sites, our ICAP team, conducted certain trainings to our colleagues on how to do these little projects for quality improvement and how to work better with the blood cultures and blood samples. Don't want to go deep into PDSA cycle anymore because Maria had a chance to speak about that a bit before that. But this is the plan, do, assess, and implement approach, so to say, and study. What is the reasoning behind it? This is the approach that requires the repetition of this cycle. So you basically collect the data, you analyze it, you learn how it works, if you're happy with what happened, you're going to the next cycle and you want to expand it if it worked well, or you adapt it, adjust it according to the reality, and then you continue with the next cycle. So you repeat these steps again and again within the same cycle, and then you repeat cycles. So if you look to the left corner, probably to us this is the right corner, there is an explanation what kind of part of the cycle it is. Planning is important in this case. We had to identify the challenge first. We did not have systemic monitoring for blood samples contamination. Then we were supposed to come up with the task, and we were supposed to do it according to the SMART principle. It needs to be specific, measurable, achievable, relevant, and time-based, of course. We also had to do the root cause analysis. Those of you who were involved into this kind of planning, you definitely have heard about the fishbone approach. We also used the so-called drivers diagram, and we were looking into the main ideas that could be included into the project to improve the situation. The priority matrix was another model that we used. Some changes might be significant, but not easily achieved. So we had to really prioritize on what could be achieved easier and have the most effect possible. And of course, we wanted to be able to assess how that was implemented. So we need to have some assessment tools. So what our colleagues consider to be the main challenge, the main problem in their facility, and what they consider to be the root cause of lack of such a systemic monitoring for contamination? Well, first of all, they did not have clearly defined and documented criteria of contamination. So people know something, but there are no clear-cut criteria. There are no instructions, there are no SOPs, and majority of facilities, let's be frank, did not have it. Number two, lack of knowledge. And we're talking here about laboratory staff, about contamination. We're talking about clinicians and medical nurses, and their lack of knowledge on how to properly collect blood for bacteriological testing. Number three, a lack of systemic registration and monitoring, and collection of only one set of vials for blood samples from a patient. And you need to have a systemic approach really to tackle that problem. What were the main change ideas selected by the participants to the project so that the situation in their sites could be improved and the systemic monitoring could be in place? Of course, that was definition and documentation of the criteria, updating the standardized operation SOP based on the data provided by our European colleagues. So basically, the SOPs have been amended, and they were suggested to their clinicians who are dealing with the blood samples collection. Trainings were conducted for clinicians and medical nurses. Well, this clinical part was kind of a responsibility of the clinicians, but the pre-analytical preparation of documents was mostly the responsibility of laboratory staff. So the bacteriologists had to come to their clinicians, to their colleagues, and basically teach them how to collect the blood. There were some periodic audits conducted, and the last 2 points here are very much focused on communication. One is about the need and explanation why it is so important really to have two sets of blood samples and how that impacts the contamination rates. So one vial contaminated out of 2 or one contaminated out of 4, that gives you a better understanding of the situation. And our next colleague, European colleague, also had a chance to conduct, it was about 1 month after the first trainings started. Sorry, he had a chance to focus on better communication between clinicians and laboratory staff. That was another very good series of trainings conducted. And that was July 2025 when we conducted the first assessment of the progress of our small projects. We were mentored by our colleagues from Europe. Later, during August and October, we conducted some virtual mentoring activities. We had a chance to present how the monitoring activities have been implemented and how they monitored the progress. And some results probably. Because the project is still going on, probably I will not go deep into figures, but let me briefly touch upon the changes that have been made. So the availability of documents, definitions, and availability of criteria of contamination allowed to identify the baseline level of contamination. And I have to say that every facility got it higher than they expected before. Training for clinicians and medical nurses improved the best practices for blood collection, and 2 sets of blood samples for every patient was another good achievement that improved the diagnostics accuracy and also improved the identification of contamination cases. And just a bit of information about contamination rates in different hospitals. The blue is the baseline level. You probably know that the contamination rate should not be higher than 3% based on the best practices. But when they finally conducted this baseline assessment, it was much higher. And their task was, their goal was to cut it down to the acceptable levels, so to say, during the project. And you can see that 2 months after, the contamination rate dropped significantly. And this is the data provided to us from the pilot facilities. And should we speak about the last component of this PDSA cycle, which is A, which is ACT, this is the time when the project is still going on. Though I have to say that many facilities have already changed their position to their training activities. They decided not to conduct it for the whole hospital. They decided to focus on different departments and go one by one. And there were also some ideas from European colleagues. They said, like, well, in the requisition form, we usually indicate the first name and the second name of the person who collected the sample, so that some additional, let's say, human failure-related components could be taken into account if something happens. So, in conclusion, I have to say that this kind of methodology could be effectively used to understand the baseline of contamination, and we can use it also to improve it. And let me also reiterate one more common thing. It is only due to cooperation that you can improve diagnostics and also very many other practical things that take place on a daily basis in a hospital. And probably is the last thing. I remember Ignat already demonstrated the link to the website of UPHC, but if you use this link, you can go directly to the lecture from Ariana Tambic-Chandrashevich dedicated to bacteriological testing of blood. Very interesting, like really interesting. If you do not know about this YouTube channel yet, please learn about that and use it. And I would like to thank our bacteriology people in the pilot sites, in the pilot laboratories very much. During the summertime, it was a busy time, I have to say, but they responded very, very nicely, and they really performed this job. They really performed well, and they really did the job very well. Thank you very much. Sorry for taking so much of your time. Over. Thank you so much. Thank you so much. So this is the due time for questions and answers session. Colleagues, can we have all the speakers available? Okay, do we have any questions to Turun about the management of Ukrainian patients in Norway? No questions. from the audience. Let me ask a question in such a case, if I may. Could you tell me the document that you created to manage patients from Ukraine? How did it help you to improve the performance of your facilities, and how did it help you to protect your facilities from spreading of these antimicrobial resistant strains?
Do you think about the procedure for the patient from Ukraine?
Так.
Yeah.
Exactly, yes.
Yeah. From the beginning, we have a procedure for everybody coming from abroad, outside Scandinavia. We have a system for taking tests of all these patients for methicillin-resistant Staphylococcus aureus, ESBL, extended spectrum beta-lactamase, and vancomycin-resistant Enterococcus. So this is already an established system. So we just make it broader because we saw that the patients from Ukraine had bacteria and resistance that we had not seen before. So the microbiologist told us, and we had a meeting, and we just changed it to broader tests. And so the system for isolation was also already established, that everybody coming from abroad are isolated in Norway. And we test for, and we use contact precautions and surgical mask. The surgical mask because of MRSA, and contact precautions because of VRE and ESBL and MRSA. So that the system was already established. So we just make it stricter and made more sure that everybody behaved right and could see that the practice was good.
How did you make sure? How do you make the implementing the procedures? I think
yeah, we had training and meeting with everybody, and the nurse, head nurse, and the nurse in the ward also were in the meeting, and we had meeting and preparing, and so we had small groups where we learned everybody and saw that they behaved right, and we were in the ward many times and could see how it was practiced in the everyday. And we had these meetings every week. So yeah, and then we also could see and got questions so we could understand that it was practiced. Was that answer to your question?
Ну, практично, в мене було питання, чи вдалося вам...
I wanted to clarify if you managed to prevent or to cut down the risk of multi-drug resistant strains spreading in your hospitals among your patients by implementing this approach that you talked about.
I think we managed, because before we started this medvac unit, we had spreading from the patient to a Norwegian patient in the hospital, in the intensive care unit, and we also had reports from other hospitals that they had the spread in their hospital. And after we established the medvac unit, we have no documentation of spread from that unit to other patients. And we take many tests of the patients, and also the system for taking tests before starting antibiotics in hospitals are very well established. So we have many tests of patients. And if they are, if we think that there could be a contamination from one patient to the next, we also take tests of the patients.
Дуже вам дякую. Це була відповідь на запитання.
Thank you so much. You did answer my question. Thank you.
Більше немає питань до пані Турун?
So, are there any more questions to our dearest guest named Turn? And then, if so, thank you so much for your presentation and for the answers. Thank you, thank you. And then the next question is to Olena Moshenets.
Питання до пані Олени. Будь ласка, надайте мікрофон.
Please give her the mic.
Обласний центр профілактики захворювань.
Область Center for Disease Control and Prevention from Mykolaiv. Olena, thank you so much for your work and to all the bacteriologists in Ukraine who's working and still practicing. I'm always saying that we need to work in a team as the clinical bacteriologists and pharmacologists and everybody else. But I have a question, and I will not have a better chance to ask that I know your works, and I would just like to ask you as a clinical pharmacist on the combination of meropenem and azithromycin. So what is the question? What is being proposed to use? There's the medication in is higher dose of meropenem in 6 milligrams per day, which is higher. They would possible daily dose of azithromycin, 1,500 milligrams. This is higher than all of the standard doses and everything else. So the question is, have you conducted randomized cohort or any kind of trials on that matter to confirm the safety of this combination? And why am I asking this? Because this area of work has successfully working among the inpatient condition in Ukraine. Many clinical pharmacists and clinicians are using this combination, and so they're using it in pun-resistant strains of Klebsiella pneumonia. And I would also have a question: is it this provoking even bigger growth of carbapenem-resistant microorganisms in the usage of those higher doses? And I would also like to say that I've been, since I'm a chief expert in clinical pharmacy, I was reached out by a hospital that they had a suspicion that the clinical pharmacist used meropenem and azithromycin and Acinetobacter baumannii pun-resistant. But as we know that it has natural resistance, so that we would not create any mistakes in the process. And I would really like to ask you if you could you explain in which cases it's easier or useful to use this regimen? And because their side effects are as well of a concern to us, and increasing the resistance as well can be there. Thank you. Thank you so much. Not really from my presentation, but thank you so much for a chance to speak about my personal passion, azithromycin. In reality, regarding azithromycin in total, it's 1.5 grams. This is not the absolute top dose. On the UCAS, this can be 2 grams a day. There is a protocol like that, and 2 grams a day. This is also not toxic. We are using 1.5 grams. And unfortunately, we do have restricted resources, and because the antibiotic is not of the brand, Big Pharma is not really cooperating with us, even though right now there are changes happening because azithromycin is being procured more and more in Ukraine. The Vista came into Ukraine, and so our national pharma started to move somewhere there. But we also know that no time we saw cardiotoxicity that is in the package insert. On the cardiological patient, we even QT interval measure it, and it didn't change. So that any specific test for toxicity was not there. And so I'm always saying that this is the treatment of last hope. So it's either death or maybe, I don't know, like maybe toxicity, even though the iatrogenic toxicity was not mentioned. And so we think that 1.5 grams is not toxic, but there was no specific research conducted on it. Regarding meropenem, then 6 grams, some I know even 12 grams we're using. On meropenem, we're not speaking of, just like really asking you, could you explain, maybe we're going to have a different conference so that we will not make mistakes, so we will not use this combination where you can't use it, so that we wouldn't have irrational use and increase of the resistance even more. So this is what I'm worried about. So right now, empirically, because the scientific line of work, right now we're speaking about the Klebsiella. For many, many years, we are studying Klebsiella. We are studying the structure of the cell wall of Klebsiella. because of the adaptation to azithromycin, so that the evidence-based database for Klebsiella there is, but we have many other patients in approaching Pseudomonas aeruginosa. Penicillin tazobactam is the best choice. Even though 3 doses per day, not 4, this is enough. Acinetobacter, that's ceftriaxone bibactam. So we didn't try the higher doses of sulbactam, and because of the insufficiency of antibiotics and accessibility of these antibiotics in the hospitals, we're working on what patient can allow. The hospital has, or the humanitarian aid from our national farm companies are coming to. So empirically, we can see that from not fermenting ones, there's not going to be having acute sepsis, but to treat fully, if we're speaking about osteomyelitis, this is insufficient. On the resistance, it's an interesting question because right now we are seeing on genomes that we have most of the cases, or the gram-negative flora, has polygene resistance to macrolides. And so this was a long gone before the combined therapy has been. So the upper gram-negative strength is having a resistance to everything, to heavy metals, to macrolides, to something that was not there in Ukraine. So we never treated the gram-negative as macrolides, but the resistance is there. So the chloric accident, so that the resistance is almost everything that was there, or everything that was in Asia right now is in Ukraine. And so when we were using azithromycin, this is not about the resistance, this is about the tolerance. That the top, all of the genetics of the resistance to the azithromycins is not providing for the tolerance to the azithromycin gram-negative flora. It's always working. And so we have some of the inpatient conditions that for a year or more has put them as the SOP. They use it in the reanimation, like in the resuscitation, the hospital flora went away. So the resistance is happening because the regimen is really strong, and then we improve. This is regarding the cohort studies. Hopefully we will be able to do that in the nearest time. We will publish it in the urinary infection. The cohort studies has been there, and right now we're preparing the series of separate. We went to the orthopedic infection, but we'll still know it. But we want to make it more profound with the genetics of the, with the proof that they have genetic resistance to the antibiotics, traditional antibiotics of choice. So we are continuing this final work. It's almost volunteering because there's no additional budget. This is why it's hard to organize people, to find resources. But thank you for watching us, and thank you for this ability. I will be more than happy to be mentioning about this area of work. This is for the experimental, right? And how are we supposed to write in our local protocols in the hospital? We have to base our decision upon something. So this is what this is better for the experts to comment this, but as far as I know, this is the law on compassion that allows to use the antibiotics not by prescription, not by the package insert, and dosage not by the package insert, if there is an argument on that side. So one scientific research, this is an argument when you don't have any other traditional approaches. If you don't have cetazidime avibactam, then what else do you have? So I think that this experimental has to be approved by the Concilium. Am I correct? I don't know. Most likely Concilium, yes, and they're supposed to get the background. How you mentioned from the previous meetings that we can use the sources of officially published. If there's an official published source, then on that you can do your protocol. But all of your steps, they're supposed to be documented, supported, and argumented with something. This is not taking from nowhere or from, I don't know. Thank you so much. Is there any more questions to Elena? And then questions to Julia on the proteus and colectin.
Будь ласка. Адміністрування антимікробних препаратів,
So
чесно.
administration of antibiotics has passed, and I thought it will be here since we are cooperating tightly in the bacteriologist and teamwork. And so regarding colectin, to be honest, I didn't clear, can you correct me from one, but colectin It was 45 years ago, and it's the reserve that's always been picked as this last hope till today's time or today's war. Right now, they started to be actively used, but from what I'm seeing, that this is the outbreak of Morganella morgani has manifested like that because of the usage of colastin, or is it the singular cases? It wasn't clear to me. Thank you. Because colastin is the reserve medication, and so empirically they're not being prescribed. So if it was prescribed as the etiologic treatment, then there had to be previously the bacteriology done. If Morganella is resistant to colastin, and to colastin for Morganella, we can prescribe it. So we are not rationally using colastin. This is why Morganella is working. Or did I understand you not correctly? No. What I was mentioning is that not we, but we have a few hospitals in Zaporizhia that we serve for surgery and everybody has the same picture. So I know that we have sputums where there has been resistant microflora from the escape group. So Klebsiella, Acinetobacter pseudomonas, and so the patient by being there in the department, and I understand that they're being treated by by colastin, they have protea and everywhere essentially in the wounds, and this is why we're making this conclusion that before we didn't see this microflora and now it's growing in geometric progression. This is why I'm pointing your attention that there is such an issue as well. We have microorganisms that are naturally stable to or not resistant to colastin. Yulia, can you also mention in that research what is the groups of patient that all patient possible, or is there any selection of patients? So we did not take into attention any pregnant women. So we took patients that has septic diseases and mostly surgical and in ICU. If there's no more question to Yulia, then the questions to Miriam. If we have questions to Miriam.
Так, питань немає в залу.
Oh, there is a question, sorry. So I would have a question. Can you, so throughout your presentation, you have demonstrated the list of antibiotics, right, for the detection of sensibility for patient in an inpatient condition of the first line or the first set of antibiotics. And you had Astroonam. And based on WHO, this is the antibiotic of the reserve, and you have Astroonam as the first line treatment. So you have the different interpretation of Astroonam as the more wider access, or why do you have Astroonam used as the first line treatment or the first set of antibiotics that is considered to be antibiotic of the wider spectrum, so to say? So for Astroonam.
Yeah, that's a good question. So I would say that in general, in Norway, we have a bit different interpretation in general for the antibiotics compared to the WHO classification. So we don't follow that one completely. We have a little bit of a different system, and I think it's about both our susceptibility data and how much we use the different ones and access. It's a bit of a combination. But with Astroonam, I would have to say that we use it very rarely. So it's not an antibiotic that we often use as a first line treatment. But I think the reason why it's at that part of the list is because it is considered less driving of resistance, that resistance driving. But I don't know. I think that Astroonam in Norway is mostly used in difficult cases with carbapenemase producing organisms and not very commonly used with gram negatives that are susceptible to other antibiotics.
Дуже дякую.
Thank you so much.
Дуже дякую. І в мене є ще одне
And I would
питання.
also have another question. So just practical one, but thank you for your answer. So you were saying that you have a few of the lists of antibiotics, right? So the sequence by sequence in usage. So the first line, second line, the susceptibility, are you doing to the whole list right away? And then you issued what you think is needed to the doctor, or do you do susceptibility testing to the first line, and only if that is resistant, you do the second line and the third line? Because if this is the second scenario, then you're losing time, right? If you first do the first line antibiotic susceptibility, then the second one. So how do you approach this and how it's done in Norway?
So we do the whole susceptibility testing every time from the start. And then we show only some of the results to the clinician. But we add a comment in our answer that says that they can contact the microbiology department if they need more options. And then that should be ready, easily ready, so that we can give it directly to the clinicians. Most of the laboratory, like all of the laboratory systems in Norway, are electronic. So it's easy for us to add some more antibiotics and send it digitally to the clinician. So we can kind of open up more options and send it to clinician if needed. And I think that also we have seen that when we introduce this system, it also makes the clinicians more aware of what they write on the lab requisition. So they more often write about allergies, a little bit more information about the infection and so on, so that it's easier to interpret if you need to add more antibiotics, if there are circumstances, if the person is pregnant, all these kind of other circumstances. So I think in that sense, it's a kind of a win-win, because you get better information from the clinicians, and then the clinicians get better information from the microbiologists. But it's very important to have a system in place where you easily can get the antibiotic you need straight away if there's a serious infection. And for instance, if there is a blood culture, we would give all the answers straight away, or if it's another very serious infection. So it's important not to lose time with the patients who have very serious infections. Absolutely.
Дуже вам дякую. Дуже
Oh, thank you
вичерпний.
so much. It was such an exhaustive answer. Thank you so much.
І у нас залишився один спікер, Людмила Іщ.
We have one speaker left, Людмила Tishchenko. Do you have? Thank you so much, Miriam. On the topic of her presentation, do you have? Can I ask?
Я хотіла запитати про,
I
можливо,
wanted to ask about, possibly not in your presentation directly, but about blood and testing. And one of the lectures, this is probably the previous year lecture, I heard the lecture, how does the effectiveness of blood culture with the volume of blood, and it was mentioning that they at least 50 cc's from two different hands. So what would you say is like more or less certified guidelines, and so this volume would be, and from two different limbs in Ukraine or together in Ukraine? So how are we solving the volume of blood? So maybe somebody can help me from the clinicians, but from what we have right now, the guidelines are absent. So there's no additional documents that would be saying that you need to do.
Сара, да, вона.
Yeah, Thanks for the question. I'll just fill in. So in this case, the hospitals that we're working with are using automated blood culture machines. So they have these standard bottles that go with the Bacti Alert system, and those bottles have a fill line. And the reagents that are in the bottle from the manufacturer are adjusted so that it should be with this ratio of blood that they indicate. Now, if there's a recommendation for a manual blood culture system, that may be something different. And the best practice is, in fact, to take the 2 sets of blood cultures from different body sites. And this is also related to contamination. For example, if you had a problem with contamination at one of the sites, then you would have a higher likelihood of avoiding it at the other. There's also some information that it may be helpful to wait some minutes, right, between the 2 sets of blood culture. In case you have like a transient bacteremia, you have a higher chance of catching the bacteria in the blood during one or the other blood draws.
Але ну загалом ви праві, тобто ну не 50, а 40. Якщо ми
But you're
беремо
correctly not 50 but 40. If you're taking at least 2 sets, then we have 40 cc's. Then this is much better than 20. And this is just about the diagnostic sensitivity. And I can also add here that we have the case definition of what is the blood and what is the infection of the bloodstream. And it says indirectly what is the infection of the bloodstream. And from that, you can understand that you need to have 2 sets of the, this is as minimum. But there is also data from the literature that is being said they matters not 2 class, not 2 sets, but 3 sets and even 4 sets for a higher representability of the results and improvement of verification and contamination. So yes, this is correct. We are speaking at least 2 sets or 2 kits. Are there any other questions? Then now can you ask our organizers to the floor? Thank you so much.
Як чудово, що ви всі знайшли змогу.
How great that you all were able to come to us. How great that so whoever's watching us online look for the opportunity to watch us, and then the recording will be present and you'll be able to rewatch your presentation, the presentation of your colleagues, because this is useful, wonderful, great, and up-to-date solution to us has been discussed in this Congress. Unfortunately, the Congress is being finished, and so we are hopeful that we will see each other at the 3rd Congress, and we will be able to show you and to demonstrate to you even more interesting solutions that the situation will be better. But I understand that everybody's working, everybody's doing an important and needed line of work. So we are all working and we are doing everything in our power to do that. So I will be finishing up the Congress. And let me just like to express my deepest words of gratitude to every medical specialist who's here, every department, IPC department representative, bacteriologist, scientist, educational expert. Just like to say thank you to the international partners, international organizations that are helping us with the implementation of IPC. And also, I would like to express the gratitude to the Armed Forces of Ukraine, because of whom we are able to be here today, and even independently of that the shelling or anything else, we feel protected, and so we need to take care of them as well when we are speaking about the medical care provision. And so I'll be finishing this session. I would just like to remind you that we had foreseen an unofficial part, and we saw a big number of interested part for the roundtables on the most widespread issues of the routine surveillance and antibiotic stewardship. And therefore, for those participants we are looking for, then please reach out to Maria. And then, we do foresee continuous professional education points. Please, technical expert, please do present to the screen the QR code, the keywords you've seen. So whoever watched us online has also been able to see them. And you do have the time till the end of today to register and then to go for the link on the platform of the Public Health Center to go for them.
Отож, колеги, ми будемо...
So, dear colleagues, we will be finishing up this session. And then colleagues that are staying for the round tables, I would propose for us to exit to catch a fresh breath so that we could organize the space. We will think the Congress is over, and I would like to thank you for the wonderful cooperation.